Educational Officer, AO Trauma India, and Task Force Lower Limb, AO Regional. Over to you, sir. So now you can please commence with your sessions in track 1. Thank you.
Okay, can we start? Can we start? Delegates, fellow colleagues, faculty from all over the world, welcome to the OTA boot camp and on the upper extremity uh, channel of this. We are indeed very lucky to have a very good faculty in this OTA boot camp this year. In fact, with last year's success, Integrace with Insignia decided to go ahead with this OTA orthopedic techniques, and this we are talking of is upper extremity track, for which I have been designated duty of program director of this track. I'm ably supported by none other than JC Jupiter, the name who is well known to us from all over the country, very popular in Asia Pacific. Uh, he comes from Boston, and of course, we all know he has done pioneering work on elbow trauma and hand and upper limb. So welcome, JC. Thanks for joining us. Then we have Michael Mckee, who was OTA president, who is now practicing in University of Arizona, Phoenix, but originally comes from University of Toronto, St. Michael's Hospital. And welcome, Mike. Thanks for joining us.
Thank you. Great to be here.
We have terrific faculty from all over the country, the Indian faculty, and none other than my mentor, Dr. Tanna, who has kindly consented to be here, and he is going to show us a video on here, elbow trauma. Thank you, sir. Thanks for accepting. And we have Dr. Prakash Kotwal, another of my North Star. So thanks, sir. Thanks for accepting, despite difficult times Delhi is undergoing. We have my good friend Sudhir Warrior, who is always there whenever I think of having hand and upper limb track of any kind, anywhere. His name is always first on the list as far as I'm concerned. So thanks, Sudhir. Thanks for joining.
Thank you.
My elder brother, Dr. Ashish from Pune. We have some family emergency, so hopefully he will join us for some few minutes. But if not, we will jump his responsibility. And we have the last star upcoming and established herself as a known upper limb trauma surgeon, Vidisha. Welcome, Vidisha. Thanks for joining. So India is going through a very tough time. Despite of that, all the faculty has consented to be here. I really appreciate that. We are going to really look at the entire upper limb, but this time a special request was to have more focus on surgical demonstration. This is not a time when we can do really live surgeries, but when I requested foreign faculty JC and Michael Mckee of showing some surgical videos, they gladly agreed. Also the Indian faculty. So if we go through the program, we have a great combination of didactic talks as well as some surgical edited videos for us. We will take a pause intermittently and we'll have good question answer session, because that's, I think, is the crux of the success and good conference, when we discuss more and clear out all our doubts. We have also taken efforts to tailor make the videos and to tailor make our talks to suit Indian needs, to suit what we face in real life situation. And once we go through all these talks and videos, I'm hopeful that we will be able to apply this in our clinical situation immediately. So without taking much of time, may I request Mike to speak on his talk on clavicle fractures. I will stop sharing. Mike, please.
Great. Thanks very much, Dr. Babhulkar. I'm going to try and share my screen here. We'll go there and view slideshow. Can you see that okay?
Yes, you're good.
Great.
Go ahead.
So I'm going to speak to you about clavicle fractures and which ones to fix in 2021. And as requested, I'm going to focus a lot on the techniques and what we do when we see one that should be fixed. Make sure I can advance here. So I have a disclosure. It's in the American Academy web-based online disclosure process. I am a designer of clavicle plates. And just to be perfectly clear, this is the kind of fracture we're talking about here, a completely displaced fracture in a young, healthy person. So all the information I'm going to give you relates specifically to this kind of fracture type, not a minimally displaced fracture, not an elderly, infirm patient, but a young, active, healthy patient with a completely displaced fracture. And this is what this talk is going to focus on, and all the information I'm going to deliver to you is based on this kind of fracture pattern. When these fractures don't heal properly, you can see the significant deformity results. And we know that the rate of non-union and malunion is higher in non-operative treatment of these fractures. And I'll demonstrate that to you in a few minutes here. But you can see the typical deformity of the shoulder after non-operative treatment of a displaced fracture with inferior subluxation of the shoulder and a real significant clinical deformity. And that's what the underlying radiographs look like. So we know that if you don't treat these operatively, there's a fairly significant rate of poor outcome. In 2019, who did I recommend surgery for? Increasing degrees of displacement. So if they had more than 2 centimeters of shortening, obvious protraction of the shoulder, and I'll show you a bit about that in a minute, et cetera, those are patients I recommended surgery for. If they had a visible clinical deformity, if you looked at their shoulder and there was an obvious asymmetry between the two sides, this is someone who'd benefit from surgery. Younger, higher demand patients, especially those who desire an early return to sports. Clavicle fracture fixation become the standard of care for most North American sports leagues, including the NFL and the NHL, for displaced fractures, because they get back quicker and they get back better and the refracture rate is lower. Earlier healing is a major benefit to the patient. So not just athletes, but other people who want a rapid return to function benefit from having these fractures fixed. If you see scapular winging, and I'm going to show a few cases of that, that's probably a bad prognostic sign if you leave it alone. We fix those in general. And of course, there's the combination injuries, multiple ipsilateral rib fractures, floating shoulders, etc. The landmark study we published in 2007 looked at operative versus non-operative fixation displaced mid-shaft clavicle fractures. And we found that, I'm sorry, this slide's upside down for some reason, must be a translation issue. We found that the overall outcome was much better with operative treatment. We did a meta-analysis. So we gathered 6 randomized trials, and there's been a bunch since then. So there's up to about 12 or 13 randomized trials now comparing non-operative versus operative fixation. And they all showed significant improvements with the operative group. If we look at one specific complication, which we don't like in the clavicle non-union, you can see here that there's a clear decrease in the number of symptomatic non-unions in the operative group. And it's very highly statistically significant And you can reduce the chance of one of these non-unions happening very, very much by operating on these fractures in these select group of patients. If you add up all those patients in those 6 studies, in the non-operative group, there were 53 non-unions out of 292 patients and 31 symptomatic malunions. So this is a significant rate of poor outcome with non-operative treatment. You can see here about 80 patients out of 290 had a complication that had to be reoperated on. And those can be significantly more difficult than fixing a fresh fracture, in my opinion, and increasingly there's evidence for that in the literature. So we know that operative intervention can reduce the rates significantly of these 2 specific complications. And we know, therefore, and this has been a conclusion in all of these studies, that primary fixation, just to emphasize it, dramatically reduces the rate of non-union and symptomatic malunion. What about scapular winging? Well, this is a patient of mine who drew this picture to demonstrate to me what was happening with his scapula. You can see how, as his shoulder rolls forward, the tip of the scapula points out, and he's showing what he thinks needs to be done to correct this degree of deformity. So scapular winging is a major issue with these patients, and they'll describe a situation as their clavicle rolls forward that they need to have their clavicle straightened out and pushed back, and that's another significant part of the overall deformity pattern we see in clavicle fractures. This is an individual who has a non-union on the left side, and you can see when he's standing there how his scapula kicks out at the back. If we see this in a patient with a fresh fracture, it indicates a significant degree of protraction or anterior rotation of the clavicle. And these are patients we typically recommend operative intervention for because they have a high rate of unsatisfactory results if this isn't fixed because of posterior shoulder pain, muscle spasm in the periscapular muscles, and a sense that their shoulder just simply isn't in the right spot. So scapular malposition, especially winging, results in worse outcome after a clavicle fracture. There's some increasing evidence to support that. And if you see it visibly at the time of presentation, it's a pretty strong indication for primary fixation in my hands. And remember as well, this is the patient who's got a severe upper body injury. He's got a number of rib fractures, a displaced clavicle fracture, and pneumothorax. I put this on just simply to demonstrate there's increasing evidence in the trauma literature that if you have multiple ipsilateral rib fractures, that the clavicle fracture does poorly without surgery. There may also be indications to fix the rib fractures going forward, but that's beyond the scope of this talk. So if you see this injury pattern, the entire forequarter is very destabilized and would benefit from surgical intervention for the clavicle, at least, in this kind of setting. What about biomechanics? If you look at it, well, pretty much the superior surface seems to resist the cantilever bending best. Pre-contoured plates are equal to compression plates in terms of strength, and both are far better to reconstruction plates. So we don't use recon plates for these fractures anymore. And really, locking provided marginal, if any, increased strength. You want to fix these fractures in healthy people with good bones, so you should rarely need locking screws. What about technique? My preferred technique is superior plating with a pre-contoured plate after lag screw fixation, if possible, of smaller fragments, and I'll demonstrate a case here. So this is a typical fracture pattern you might see with a large anterior butterfly fragment here, done through a small incision. We're able to find this piece. You don't want to strip it of all soft tissue. You want to keep that soft tissue attached while you put it back into place. And obviously this fragment is big enough to warrant fixation. We place a mini fragment screw connecting it to the distal fragment now that we've created a simple fracture pattern. Another mini fragment screw to hold the whole thing together. So now we have an anatomic reduction, good length and rotation we established, and you can see we have maintained soft tissue attachment to that fragment. And then we follow that with a pre-contoured plate. These have made fixing these fractures dramatically simpler in my hands, and I think they've become the standard of care because they're easier to apply intraoperatively. They reproduce the shape of the clavicle, and they have a lower removal rate. This is an example of that patient. You can see good fixation here. And this patient is basically allowed to do immediate range of motion afterwards. Usually I hold off resisted for 6 weeks and sports for 3 months if they're a contact sports athlete. I think pelvic reconstruction plates in isolation are too small and have a high mechanical failure rate in multiple series, so we don't use pelvic recon plates anymore for this fracture. And this is an example of what can happen. This was only about 8 weeks out, and this plate broke rapidly. A large North American male who was not particularly compliant, but is just simply not strong enough for this kind of individual. But remember that this operation is a finesse operation with a narrow risk-benefit ratio. Fixing a femur fracture, it's life-saving, it's almost indestructible, and we do it with everyone who comes through the door. The clavicle fracture is for select individuals. It improves upper extremity function, so you have to be really careful in who you choose to do this operation on. It's a judgment with you and your patient, and you have to be careful with that. Thank you very much for your attention. It's been great to be here. I very much appreciate the invitation, and my kudos to Dr. Jupiter, who taught me a lot about the clavicle. Thank you.
Thank you, Mike. If you can unshare your screen, I will.
There we go.
Yeah, thank you. I will take my next talk, which is on acromioclavicular joint injuries. Can you hear me? Can you see me, everyone? Okay, so we know acromioclavicular joint injuries are mostly seen in sports people, but of course it's directly fall from height, and you can see the deformity, which is very obvious once you see it. We have to x-ray them, anteroposterior and 30-degree cephalic tilt view, but the most popular is the Jhankaria view, which will tell you the coracoclavicular distance and also the acromioclavicular disruption, but mostly you need to compare with both the sides. Jhankaria views. Stress views are very rarely used these days, but maybe sometimes if there is a tenderness medially over sternoclavicular joint, it is a good idea to do a CT scan, because that's where the sternum is and that's where the clavicle is. In this particular case, it's better to know where and how the clavicle has moved medially as well. We need to know the surgical anatomy if we are dealing with acromioclavicular joint injuries, and the most important are these two ligaments, trapezoid and the conoid part of coracoclavicular ligament, which needs to be understood well if we have to reconstruct and think of surgery of acromioclavicular joint, and we'll talk about it very soon. MRI would also tell us about the associated soft tissue injuries, especially these ligament status, wherein we can look at the acromioclavicular ligament as well as the trapezoid and conoid part if they are disrupted. Acromioclavicular continues to be the primary constraint for posterior displacement, more than 90% of it. We have seen that if we keep AC ligament intact, there is very rarely AC joint instability. The moment we transect it, it can lead to anteroposterior translation. So it is important. If you look at the traditional classification, it was into 1, 2, and 3 types, and Rockwood has added 4th, 5th, and 6th type into it. So type 1 is just a sprain wherein the AC joint per se is intact. The ligaments are mostly intact. There is no muscular disruption. Type 2, less than 50% vertical displacement, but some amount of ligamentous disruption. Type 3 onwards, it goes on more severe ligamentous disruption with more severe displacement of clavicle. As is seen here, there is a type 3 variant, which is the pseudo dislocation. Type 4 is acromioclavicular and CC ligaments getting more disrupted, and obvious clinical deformity also seen in type 4. Some amount of muscle disruption from the distal clavicle of deltoid and trapezius. Type 5 is more acromioclavicular and coracoclavicular ligamentous disruption completely, with almost complete disruption of deltoid and trapezius. And type 6 is the worst of the element wherein the clavicle gets inferiorly dislocated. Treatment options for type 1 and 2 mostly is non-operative, and we can just give them a sling and expect good clinical result. So some demanding sports injury patients can have or can be considered for operative intervention in type 2. In type 3, we are sitting on the fence between non-operative to operative. If at all we consider operative, it can range from primary acromioclavicular joint fixation to CC ligament reconstruction. to excision of distal clavicle, which was considered, and to some people considering even dynamic muscle transfers in chronic disruption cases. As I suggested, type 3 patients are sitting on the fence, and there is a division of literature between considering operative or non-operative in type 3 injury patients. Functional outcomes seem to be similar in both. So indications of acute surgical treatment in type 3, very active patients, and very clearly in type 4, 5, and 6, we can consider on first instance surgical options. Surgical options, as I suggested, can be these 4, wherein there is you can consider coracoid process transfer, primary AC joint fixation, primary coracoclavicular fixation, and CC ligament reconstruction, with some people adding to it distal clavicular excision. So this is the first example when there is a open repair of acromioclavicular ligament with supported K-wire fixation. 2 months later, one can remove and expect this kind of a clinical result with this kind of a radiological result. And long term, they tend to be doing good if there is a good associated stable acromioclavicular ligament repair associated. There is a very popular acromioclavicular surgical reconstruction which has been popularized as coracoclavicular ligament reconstruction in a biological way with distal clavicular resection, very popularized as Weaver-Dunn procedure, wherein a good result and good amount of published literature is available, with some surgeons swearing by this procedure. My preferred method is anatomic reconstruction, wherein coracoclavicular ligament is biologically reconstructed, a method popularized by Mazzocco, wherein there is a incision taken on top of the acromioclavicular joint along Langerhans lines. As such, a deep dissection including fascia. I prefer to harvest semitendinosus, pre-tension the graft. I prefer to excise distal 5 to 8 millimeter of clavicle as seen here. Always deltoid is to be split and we should not take the flap. Along the footprint of trapezoid, we can drill the hole. We have to measure from the distal end of clavicle, and the first hole for trapezoid tunnel is to be made more than 2 centimeter. Here it is coinciding with the 3 centimeter mark. Conoid tunnel is approximately at 5 centimeters. We can drill the tunnel, which is more placed anteriorly, and then the pre-tension graft is looped through along with fiber wire. Some people prefer to just loop it around coracoid. Some people prefer to put a interference screw or a suture anchor there at the coracoid to cause the tenodesis effect. So that's how the interference screw will go on the conoid ligament, and the accessory ligament graft can be pulled across. So that's how we do it. Loop symmetry around coracoid. We have talked about the drill hole, rasp or skeletonize the coracoid to have a better graft attachment there, and then you can loop it around and tie it to have this kind of a picture, and that's how you look at the tunnel there. The excess graft can be used to reconstruct the acromioclavicular ligament by putting it on the top of it, and then you suture the deltotrapezial fascia to have a good closure. Literature is full of various types of techniques, but this particular technique creates a biological as well as a mechanical coracoclavicular ligament, and the excess ligament can be put to reconstruct the acromioclavicular. So that's my favorite, and that's giving most of the people who are users of this a good clinical result as well. So to conclude, it's a good anatomical technique. Semitendinosus seems to be better. Double loop to mimic conoid and the trapezoid part of coracoclavicular is a good idea. We should split deltoid and not take down. It's a simple surgery, and once you learn it, it will give you a consistent and predictable result. Thank you very much. After me, I think we are back to Mckee. Mike, do you want to take your talk on proximal humerus, please?
Okay, I'll do that. Let me share screen here. Put that on. Just give me 1 second here to get that up.
Sure.
And give me 1 second here. So I'm going to talk about proximal humeral fractures and the importance of tuberosity-based fixation. I'm going to put the slides on here in 1 second. So I'm just having a little trouble getting the slides up here. Hang on. Can you see my screen okay?
Not yet, Mike.
Not yet? Okay, let me try this. How about that? Can you see it now?
You're on.
Okay. And we'll go to slideshow. There we go. Great. Is that okay? You can see now, Sushrut?
Good. Yeah, good. Yeah.
Good. So I'm going to talk about proximal humeral fractures and the importance of tuberosity-based fixation. And this is going to, I think, flow nicely into the next talk by Dr. Kulkarni. We know that RCTs of operative versus non-operative treatment, generally speaking, don't show much of improvement with surgical fixation of these complex proximal humeral fractures. One of the main issues is that if you operate on one of these individuals and you do a good job and it heals, they do very well, but the complication rate is significant, and we still haven't perfected the way of reducing these complications in proximal humeral fractures. If you look at these studies and you look at the subgroup of patients who had surgery and healed promptly and in a good position, they are the best subgroup in this series. But overall, the results are significantly dragged down by the number of people who have complications. And we all know that complications with proximal humeral locking plates are very common. I think this is a major problem with these studies. We can't consistently get these fractures to heal. At the American Academy in 2019, the last time there was a in-person American Academy, I was at an ICL looking at proximal humeral fracture locking plates. And I asked the audience in an audience response question, what problems do you have with these plates? And overwhelmingly, the number one issue was tuberosity fixation. The current proximal humeral locking plates don't fix the tuberosity very well. And that's a major issue, as well as the other things you see here, including screw penetration, the joint, loss reduction, et cetera. So tuberosity fixation in the average orthopedic surgeon's hands in North America remains a problem. And this is an issue no matter what you try and do. Here I placed the plate quite high. I put sutures to the tuberosity, et cetera. And then this happens. And this picture is a disaster for the patient. When the tuberosity pulls off like this, it's simply very, very difficult to bail out of this situation. If you look at Gilles Walsh and Pascal Belot from France, they've looked at what's the problem here. Well, they found that the proximal humeral locking plates in existence really have no tuberosity fixation. The plates are on the side, the tuberosity is up and in the back and in the front with a lesser, and you simply can't fix those fractures with the plate, and that's a major problem going forward. We all put sutures in the tuberosity in the cuff and try and suture them back down to the plate. Unfortunately, if you look at this biomechanically, it doesn't make that big a difference. I still do it because we don't have a lot else at times, but it doesn't make much difference to the stability of the fracture. And so suturing the tuberosity may make you feel a bit better, but it often doesn't really help the biomechanical strength of the construct. And there's multiple papers that would show that. Here's a recent paper from Germany showing we still have significant issues with fixing these fractures in older patients. There was a significant complication rate in this 2020, a modern paper from a good center with good surgeons, and they showed a complication rate of 32% with 27% of patients requiring revision surgery. This is way higher complication rate than we'd accept in any other fracture. 27% of patients required unexpected revision surgery. And this is what they found. in that paper, and this is actually a picture from that paper, if the GT pulled off, and it did in 25% of their patients, it was a huge risk factor for having a bad outcome, worse than head shaft malalignment. So if you had a GT pull off, it was a 3.1 times increased risk of having a poor outcome. That was worse than having head shaft malalignment. So GT pull off remains a concern even in 2020 in these patients. I used to use the cloverleaf plate. This patient was referred to me late with an obvious GT issue. I used to use the cloverleaf plate, which is an old-fashioned plate way back in the day, described by Rennie Esser for using fixation in proximal humeral fractures, because it gives you a time to grab the tuberosity. And I felt this was very important in these fractures, and we developed the plate around the tuberosity fixation. This is the design of this plate, and you can see that it has flanges on it that are contrable to fix tuberosities, and one of the styles has a hook on top to actually hold that tuberosity in place. So if you look at the literature, in 2020, there's still a high complication rate with these fractures. GT pull-off is a major issue, and that's something which even suturing it back down doesn't routinely solve or fix. We looked at this plate biomechanically before we started using it to see if it did a better job. So this is our experimental model. You can see the hook plate, or the Phoenix plate as we call it, on the left-hand side, holding tuberosity in place, and a standard locking plate beside it. And there's a radiographic representation. And as you would expect, if you look at our experimental model here, we're pulling on the tuberosities to see what kind of fixation we have. The ITS plate, or the Phoenix plate, which is in red, was dramatically superior to the regular proximal humeral locking plate, almost 2.5 times greater stability, so to speak, than regular suturing of the plate. So we know that biomechanically this plate works well and does a good job of fixing the tuberosities. These are some of the first clinical cases with this. Now, this particular case does not have a huge tuberosity issue, but I'm showing this case because you can use the tines in the plate to really hold the fracture in place. Another nice thing about the plate is it's impossible to translate the head off the shaft. When the head is in between the two anterior and posterior flanges, then you know that the head has to be on top of the shaft. And that's another issue when fixing these fractures. And so this was a very gratifying case, although agreeably not a very complex fracture. If you do have a large GT fragment, then the hook portion on the plate also is very useful in holding that thing down. And that's the superior biomechanics that we showed in the biomechanical study, which is published in the Journal of Orthopaedic Trauma if you're interested in looking at it. Here's a 58-year-old female with an impacted 4-part valgus fracture. I think we'd all agree that while this fracture might heal like this, and probably would heal like this, if you left a patient like this, they'd have a significant mechanical problem with their shoulder in terms of impingement and lack of rotation, and probably wouldn't have much overhead function down the road. We fixed this fracture, and these are intraoperative radiographs demonstrating what we did with the plate, and you can see how we're sort of corralling or holding the tuberosities together. We've got the hook in the tuberosity fragment. This is her 8 weeks post-op with good solid union. You can see everything's healed, and her clinical function is pretty good. She's still working on motion, and there's no impingement. So when you use this plate, rotational impingement as well as superior subacromial impingement is a bit of a concern, but you can see this patient really doesn't have either of those two things going forward. We've seen a remarkably low rate of impingement with this plate clinically. I'm going to show one last case for the sake of brevity, and I'm sure we're going to hear a bit about fixing proximal fractures in the next talk, which I'm looking forward to. There's a 41-year-old individual who had a bad mountain bike accident and came in with an axillary nerve palsy and also this fracture dislocation of the shoulder in December of 2019. You can see there's a significant greater tuberosity fragment. If you look at that piece in the picture in the middle, you can see that large fragment there. This we fixed with the Phoenix plate, and you can see we've got a good reduction, and we have that tuberosity secured with the tine on top of the plate. This is that patient about 3 weeks later. You can see there's a bit of an inferior sag to the joint because of his deltoid atony, although fortunately that came back in this particular patient. And this is him 7 months later. We have solid bony union. His axillary nerve recovered and his deltoid atony recovered, and you can see pretty good motion here. And you can see that he doesn't have any impingement in rotation, which is gratifying to see, and very good motion considering the severity of his injury initially. So to conclude, I'll say that most patients can and should be treated non-operatively at the present time, and most RCTs don't show much improvement with fixation, but that's because of the high rate of complications. There are some good principles used if you want to maximize success, and I'm sure we'll hear about that next. And then lastly, there are some advantages to tuberosity-based fixation in this specific fracture pattern. And thank you very much for your attention. I look forward to the next talk by Dr. Kulkarni.
Thanks, Mike. Vidisha, ready?
I'll stop sharing.
Yeah, if you can share your screen, Vidisha, and start your surgical video on proximal humerus operative.
Can you see?
Yes, we can see. Just do your slideshow. Yeah, okay.
So after very nice talk on tuberosity fixation with clover leaf plate, we are here for fixation of proximal humerus with Philos type of implant. So this 38-year-old lady presented with fresh trauma to her right shoulder. X-ray showing displaced tuberosity, displaced neck fracture with varus angulation and displacement of the shaft. The 2D reconstruction CT image and the 3D CT images are showing comminution of the lateral cortex as well as fracture lines running through the GT and LT. So open reduction internal fixation was planned for this patient. And the patient was positioned supine. The first step is to palpate the coracoid, and the skin incision is made distal to the coracoid for about 8 to 2 cuff and the medial cuff. These sutures help to derotate the head fragment over the shaft. You can pull the tuberosities and bring them together if you use extra sutures. So if you use 2 sets of sutures in case the tuberosities are displaced, then the first set is used to bring the tuberosities towards the head and tie them together. And the second set of sutures can be used through the holes of the locking plate. The next step is to identify the long head of biceps tendon and trace it proximally. This tendon is then retracted laterally, and the conjoint tendon is retracted medially, and then the head is slightly rotated externally to get purchase over the subscapularis tendon, and a nice sutures are taken through the subscap. It is important to slightly dissect the pectoralis major insertion for about 1 centimeter or so. Similarly, the deltoid insertion is dissected a little bit for about 1 centimeter for placement of the plate lateral to the bicipital groove. The next step is to reduce the head over the shaft. This is done using a joystick maneuver. A clamp can be used for this, and the head is pulled down in a valgus position, which is temporarily fixed with provisional K wires. 1 K wire going from head to the shaft fragment, and another K wire going from tuberosity anchoring the head, and the third wire is inserted from shaft into the head fragment. This is checked under image intensifier in different views until the satisfactory reduction is achieved. The AP view and the axillary view. If the alignment is okay, it looks okay in AP view, it is again checked in the axillary view. And if it is okay, the wire through the tuberosity can be advanced to anchor the glenoid if necessary for temporary fixation. And then the plate is positioned. It is important to position the plate distal to the tip of the GT in order to prevent impingement, at least 5 to 8 millimeter distal to the GT. It is important to look under the image different rotational views. With shoulder in adduction, shoulder in abduction, internal rotation, neutral rotation, as well as external rotation, till you get satisfactory alignment of the head with the shaft in both the views. Then the plate is applied. It is temporarily fixed to the shaft and the head with K wires. The lower end is also fixed with a K wire through the lower hole. And the calcar wire is put, if it is okay, under IITV. There is an oblong hole through which we can put our cortical screw. The drill is made in the center of the oblong hole so that if the plate is proud, it can be taken down, and vice versa. If the plate is too low, it can be shifted upwards. This is critical, this screw, because this screw pulls the shaft towards the plate. So this cortical screw, once it is tightened, will again cause valgus reduction of the shaft over the head. Once the shaft screw is inserted, then the remaining screws in the head are inserted. The first row, second row, and the third row. Calcar screw is then inserted. It is important that the calcar screw should have purchase over the inferomedial quadrant of the head in order to prevent varus collapse of the head. Then the first and second row screws are inserted. It is important to use smaller size screws, at least 5 to 10 millimeters smaller than the actual measure. It is again checked in various rotations, internal rotation, neutral rotation, as well as external rotation, to check whether the screw has penetrated the joint or not. It should be 5 mm less than the subchondral bone. These rotational images are taken in shoulder abduction as well as by adducting the shoulder. It is important to place the plate lateral to the bicipital groove. It should not encroach the long head of biceps in order to protect the anterior humeral circumflex vessels. Distally, this is done by slightly releasing the pectoralis major and the deltoid insertion so that the plate is exactly centered in axillary view as well. So this gives a nice purchase of screws in the shaft, as well as the calcar screw sits nicely with this plate placement. After the 5 or 6 screws are put in the head fragment, then 2 locking screws are put in the shaft fragment. It is again rechecked under the IITV, the placement of the screws and the penetration of the head. The humerus is rotated and flexed and abducted to see whether it impinges whether the plate impinges the acromion. When the all fixation is achieved, then the sutures are pulled out through the small holes in the plate and tuberosities are tied over to each other. So this gives additional fixation of the tuberosity with the plate and to each other. You should not hesitate to put extra screws outside the plate if there is comminution or additional fracture of the GT posteriorly. You can put screws outside the plate. So this plate is centered very well in the axillary view. And once the sutures are tightened, then the pectoralis major as well as the deltoid insertion is sutured back, and the deltopectoral interval is closed. It is important to check forward flexion and abduction intraoperatively. We don't have these clover leaf type of plates, but this calcar screw is fitting nicely. Gothic arch is reconstructed, and the screw length in the head is pretty good. So this is immediate post-op X-ray of the patient 3 weeks later, And this is the rehab going on in the immediate post-operative period in supine as well as in the standing position with passive physiotherapy. So the key to a successful outcome is depending on valgus reduction of the head over the shaft fragment, proper and secure tuberosity fixation, both the tuberosities. Calcar screw should engage the inferomedial quadrant of the head in order to prevent varus collapse. The implant or the plate should be positioned at least 5 to 8 mm distal to the tip of the GT and lateral or posterior to the bicipital groove. Thank you.
Thanks, Vidisha. If you can unshare your screen, please.
Yes.
That was a great talk. I have one question for Mike. Mike, it's a terrific design that you have made. And
Yes.
what really impressed me was the low profile nature of the plate and the grab around capacity of it. My question is, of course, anything new attracts orthopedic surgeons more, as always.
Yes.
Are you satisfied with the irrespective amount of comminution at the greater tuberosity and the associated rotator cuff damage? Does your design plate grab almost all the fragments?
Yes, in general, it does. So you can use the two top tines to get the majority of the top sleeve of the cuff and the tuberosity together back into place. And that's a good way of securing tuberosities that are fragmented, because it can be quite difficult otherwise to hold those things, as you know.
Yeah, yeah.
So we've been very satisfied with that. Much better than just, we use suture as well, no question about it, for cuff tears, as Dr. Kulkarni showed, absolutely. And we make that whole big sleeve, one sleeve with sutures, but then fixing it to the plate, the hook is extremely satisfying compared to conventional fixation.
Okay, so on the similar lines, you have a couple of questions here, and I have shared the screen for you. So the first question is there a possibility of loss of active abduction following greater tuberosity screw fixation? Mike?
No, in general, there's not. So we worry about impingement, but usually if you sink the plate down into the tuberosity, then that doesn't happen. So we've put about 50 or 60 of these plates on. I think we've taken off one so far for impingement. And so it works very well that way.
Next question from another senior colleague of mine, Dheenadhayalan, is do you do suture fixation of tuberosity with the hook plate?
Yes, we do. So we use sutures as well in the standard fashion for that. And just as Dr. Kulkarni. And sorry, I have a visitor here today. And that's worked out very well. So we do the conventional things as well. There's no question that's very useful. But then we also tie those sutures to the plate to help augment the fixation. But the hook is the main thing there. And that's really made a huge benefit to this going forward.
Okay. Shivam is asking if Phoenix plate is useful in preventing head shaft malalignment. And my extension of this question is, will it also act as a template laterally to correct your malalignment, Mike?
Yes. So if the head's in the middle of the two flanges, then you can't translate it off. And I've seen many proximal humeral fractures fixed with translation, where the head is translated posterior to the shaft. So the Phoenix plate allows you to put the head in the middle of the flanges. Then if the shaft of the plate lines up with the shaft of the humerus, you can't be off. It has to be corralled in the right spot there. So it eliminates translational malalignment. You can still rotate it poorly or leave it in too much varus. It doesn't stop that. And that's where the techniques Dr. Kulkarni showed are very important. But the one error of translational problem, that is eliminated by the Phoenix plate. That just doesn't happen anymore, which is nice.
Yeah, terrific. My question to Vidisha is, Vidisha, you always prefer a deltopectoral approach, or you use deltoid split also sometimes?
Mostly deltopectoral, very rarely deltoid split. If at all I'm using
what's your take on the approach, Mike?
fracture extending into shaft, and if I have to bend the plate, and then I might use deltoid split approach.
Okay.
I agree with Dr. Kulkarni. There is some evidence that there's a randomized trial from Montreal that shows, in general, the deltopectoral is a better approach. Occasionally, if there's a lot of posterior pathology, as Dr. Kulkarni pointed out, then it's worthwhile doing a deltoid split. But in general, deltopectoral.
If I may rope in, Dr. Tanna sir, what is your preferred approach? Deltopectoral, deltoid split, and more elaboratively on this. Unmute, please.
You know very well, I am more fond of a deltoid split.
Yeah.
I think mainly because the tuberosity is much easier to reduce, more so when it is displaced posteriorly. And in the deltoid split, I don't do the conventional one where 2 incisions. I open up and I see the nerve, and I open out the nerve, so that I have no hesitation doing the surgery thinking where is the nerve lying there. So I think it is much more easier, and you will be able to see the nerve almost every time at about 2 inches or 2.5 inches. You take out the nerve, and then you will be able to do the same situation, whatever you were doing it with the deltoid, with the deltopectoral. You can do exactly the same thing with the far more easier access to the posterior tuberosity.
Jesse, you have any special take on this approach?
No, as was mentioned, I think if you have posterior involvement, perhaps a deltoid split, that otherwise would require a lot of elevation of the deltoid if you go from the front. Otherwise, I think deltopectoral is generally adequate.
Okay. My question to you, Vidisha, is, do you always suture your soft tissue around the plate? Is there any instance when you try to grab your soft tissue with your plate?
I usually suture the insertions with the one suture and the close the interval. But if in case of compound fractures, I may not take sutures through the insertions.
Okay.
For close fractures, I do always.
Mike?
May I ask a question, Sushrut?
Yes, absolutely. Please.
With this Philos plate, we have observed that the range of movement which the patient gets is not going to be that very good. It takes a very long time and the range of movement is compromised. While if there is only a tuberosity reconstruction, and then even the few K-wires or a few screws which have been put in and try to get the late mobilization, the range of movement is comparatively better than with the Philos plate. Any opinions on that?
Mike, do you want to take this? Because I really loved your low profile concept.
Yeah, I think that the stronger fixation you have, the earlier you can move the patient. There's no question about that. And GT pull-off is a thing that we're all concerned about, that way we don't move the patient early. And if you can get good fixation to the GT, you can move someone. I move patients immediately the next day, so it generally leads to much better range of motion in the long run if you can do that.
Jesse, you want to say something on this?
No, I've always thought that trying to fix this three-dimensional fracture from one direction never made sense to me. So this is a very logical way to embrace the tuberosities. And range of motion is what ends up to be the outcome measure that patients look at. They don't really worry so much about union. They worry about getting overhead motion in many cases. So the more stability you have, the better you can proceed in that rehab.
I will elaborate on where this question of Tanna sir has originated from. So we started with the huge fashion of Philos plate. We started doing it left, right, center for any 2-part, 3-part, 4-part fractures. And because of superior placement of plate, it abutting against the acromion, because of wrong placement of plate, because of inability to hold the sutures, suture anchors, comminuted fragments with the plate, we started getting more and more compromised results functionally. So though X-ray would look good, patient's function would not be so satisfying. And suddenly, Mike, paper came from Canada suggesting elderly people getting better range of motion even in comminuted fractures of proximal humerus. So the world got confused as like distal radius, whether we should opt for non-operative or operative or minimally operative, wherein you just put all the comminuted fragments together, do repair of the soft tissue part, but do minimalistic fixation by K-wires so that you can fairly mobilize the shoulder early on. So to me today, the minimalistic fixation of a narrow plate but a strong plate, which you have suggested, probably is the middle path regime for this fracture. Tanna sir, any comments?
No, I think the plate which Mike has put in, I want to ask him whether you find that the range of movement which you get with that sort of a comparatively thinner plate is much better than Philos than for your plate.
In my experience, the range of motion is better because we can let patients move right away. And even though it looks like a fairly bulky plate, the flanges are shy of the articular surface, and you can see the rotation these people get is not restricted by the anterior and posterior flanges. And you have the confidence to literally move them right away the next day, and you don't have to worry about GT pull-off. So it's a very much improvement over what I had in the past with the regular conventional locking plates. And I don't have that GT pull-off, which was, if you have that GT pull-off in a young active person, I think we'd all agree that's an almost irretrievable situation. Very difficult to get out of in that situation. So we don't have that GT pull-off, which is very encouraging to move someone early.
And I also see that for that hook to get embedded, you have to push the plate down, so there will be no way that it will get superiorly placed initially, at least.
Correct. We've had 1 or 2 cases where we did not do that and patients got an impingement. But I would say this, if the fracture heals in a good position and you have some impingement from the plate, that's an easy solution. You come back and take the plate out and everybody's happy, the shoulder's good, and release the subacromial space. The corollary of that is if the GT pulls off and gets stuck up there, that's an almost insoluble problem. So I'm happy to accept that complication rarely in order to get that where the tuberosity healed where I want it, basically.
I give the GT is a split GT. It is not a one-piece GT, but it has been a cumulative problem. And particularly the posterior part is not visible so easily. So in that situation, have you ever seen that you have missed the posterior part in order to try to put the hook thing? And then in the post-op X-ray, even on the table, you see there is a part of the GT which is still flying up.
Yeah, so that's an excellent question, and that has happened to me. Once we have often multiple pieces, and we try and pick the biggest one and bring the rest of the rotator cuff to it. But I have missed that once or twice, and that's a major issue when you have missed that fragment, and that we had to come back and refix. So it is possible if the fracture is comminuted to not get the whole thing with the plate. So we try and put it where the biggest piece is and bring other pieces to that.
And that's the reason post-operatively, when you see the X-ray, if you see some bony fragment which is lying away from the main piece, then you know it's mainly the posterior part, which is also the attachment infraspinatus. And that's the reason why on the table you will have to be very, very careful to see that the whole GT is seen in a different rotation.
If I see that on the table, then I will try and fix it on the table for sure, because we know that's not a good thing.
Yeah.
And if you can bring the shoulder into more internal rotations here on the back better, and then try and fix it back down the plate. And the plate has, the usual holes for sutures through it, just like the regular plates. If you see it post-op, you have to decide, is it worth going back for that or not? And that's a long discussion with the patient. The older the patient, the more infirm they are, the less likely I am to reintervene. If I had a 38-year-old patient like the one Dr. Kulkarni showed and the GT had pulled off, for them, I'd recommend we have to go back and redo this because you'll have a miserable shoulder otherwise. And we all know that the bailout for all of these things, if things really go poorly, you have no cuff and the tuberosity pulls off, the bailout's a reverse arthroplasty, which is an okay solution for a 75-year-old, but not for a 38-year-old. So the bar for re-intervening is much lower in the younger patient.
Okay. And the last question is from Hari. He asks, hook plate preferable for AC joint? We have been there, done that. Hook plate is not good anymore. We used to do that, but lot of issues. You have to really correctly place it. If it is not correctly placed, it gets displaced, causes impingement. So largely it came and it's been given away with. JC, I know you have a lot of work on hook plate for AC joint. Do you want to speak a line about that?
I think the manufacturers made it too big, and it always has to be removed. And I don't feel that it's as good an option. And Mike Mckee and his group looked at that as well, and I believe we're not as enthusiastic. I just want to add one thing, that I think the big issue is trying to determine which cases will do well of the proximal humerus fractures non-surgically. We're currently looking at a large group of patients treated non-surgically and trying to determine, can you find more definitive parameters? Because I do think that surgery, as was pointed out, still has unfortunately too great a complication rate that we shouldn't tolerate.
I would agree. Sushrut, if I could just add one brief thing about the AC joint. Jesse's correct. We did a randomized trial looking at hook plate versus nothing, and it really didn't show much difference in the patients with a high-grade AC joint separation. But some patients definitely do need an operation. And the one situation which is bad is if you over-reduce the AC joint with hook plate. It's very easy to over-reduce it and bring the clavicle down too low. And if you do that, then bad things will happen going forward. So if you do use hook plate, and there are some newer varieties out there that are much lower profile, much less bulky than the original plates we had, and have a hook that contours to the clavicle and to the acromion much better, then that's probably a successful way, as long as you don't over-reduce the clavicle when you put it on. So I think that's an important point with the hook plate use. So we still use hook plates regularly. The newer ones, the less bulky ones, we're very careful not to overreduce it. So we take a X-ray intraoperatively to make sure we haven't narrowed that coracoclavicular space too much.
If you do only the hook plate without any reconstruction of the coracoclavicular ligament, when you remove the hook plate, still the whole damn thing flies out.
So here's the point there. If you use a hook plate for an acute injury, so within 3 weeks of the injury, number one, and number two is you leave the plate on for a minimum of 6 months, then the rate of loss of reduction is very low. Yeah. If you use the hook plate for a chronic situation after 4 or 5 weeks, 6 weeks, 3 months, a year, you have to do something else. I agree with you completely. Yeah. Or if you take the plate off too early because it's really bothering the patient, again, that leads to redisplacement. But if you use the hook plate for an acute injury within 3 weeks of injury and you leave it on for a minimum of 6 months, and in our study, the hook plate stayed in for an average of 8 months, then the rate of loss of reduction is very low, actually.
Yeah, terrific. Okay, so shall we move on?
You are the boss.
Okay, so let's move on to the next thing, which is oligramon. And we know about classification. Again, as we tend to speak about displaced and undisplaced terms, we will restrict this talk to displaced fractures, and we will look at when tension band wiring is okay, when plating should be done, and when the third option of some amount of shortening and plating should be contemplated. So tension band wiring, of course, has to be done the right way to have good effect of tension band and adequate forces created so that we create a stable environment around olecranon. Works mainly in a stable displaced fracture which is non-comminuted, and we have to make sure that our K wires don't float in the canal but have a purchase on the opposite cortex there, because otherwise there is a huge percentage of K wire migration and the pull out of K wires, and it pushing on the skin and patients getting irritated, and there is a huge literature to support that. My friend Kim has designed this eyelet at the middle of this K wire. So you push in the K wire there and you wrap around the tension band wire around that eyelet. Achieves two purposes: makes sure that there is no back out of the K wire and there is an adequate compression created at the fracture site. So I thought this is a pretty neat idea to be used if we want to use tension band wiring and want to use K wires. But otherwise, mostly to create good compression all along the length of the fracture, it's imperative that we have a purchase on the opposite cortex to have uniform compression across the fracture site. Couple of examples. That's how, if not good compression, good thickness of K wire is used, cerclage wire is used, the fracture will soon open up, and then with this some amount of comminution, the easy way for tackling this kind of a situation of backing off of the K wire and loosening and separation of fragment is to just add on the plate in addition to the tension band wiring. So it can be a two modalities used together. Some amount of comminution again at the articular surface as well as on the posterior aspect is to deal with the articular surface fragments with these tiny K wires embedded or buried in the bone, and to use a plate all across. Again, some amount of comminution which is obvious on the CT scan, may use some K wires, but plating would yield a good purchase of all the comminuted fragments put together and having. So how should the plates be used? Should there be two plates put laterally or medially, one plate kept posteriorly, or one plate with this screw home? Obviously, the most biomechanically strong construct is when you put this screw going all across, which is the main screw going in the intramedullary canal and causing compression and a good biomechanical strength. We can, in situations wherein there is a huge amount of comminution which is non-reconstructible, consider some amount of shortening and create a stable situation. How much shortening is, we must not lose more than 1/3 of the articular surface, and then doing a good amount of plating and use those comminuted fragments as grafting at the primary site. So when to opt for plating and not tension band wiring? Of course, tension band wiring in non-comminuted situations, minimally displaced, is a simple and cheap option, is a faster way, but with a higher incidence of hardware related problems. So we should know that. So we should also know that it needs absolute meticulous technique, and to avoid problems in comminuted situation, of course, this kind of a plating, and now plates are available anatomic which are made for left and right side, and you can very easily do this operation. And remember, this screw is the most important screw which will give a good purchase and a good stable reconstruction even in comminuted situation. So again, this is an inadequate fixation, and when we started doing plating, that's not the right screw. This screw should have been not there, but something like that to have a good compression effect. We also used hook plate in some situations, but this fragment must always be fixed, otherwise this might lead to elbow dislocation early on. We were lucky. We could escape that, and there was good fracture consolidation, but that's not the way it should be done. Another problem with the hook plate is prominence of this hook plate. May it be in acromioclavicular situation or may it be in olecranon situation. Hook plate used here causes metal to be more prominent. So osteoporosis, comminution, plating works well as is seen here. Again, couple of examples of comminution and osteoporosis. Plating would do the trick. So osteoporosis and comminution, plating seems to be a better way than tension band wiring. But there are some points we must remember. There should be at least 3 screws in the proximal fragment. Again, as long as possible screws. Interlocking structure has to be used. We can use bone cement to augment combinator fragments, and pre-contoured plates seem to be better for olecranon. So similar to distal humerus, there are these set rules of the game. What is the contribution of olecranon in elbow stability? Very, very important. So if there is a coronoid disruption and loss, we can use this portion of olecranon to reconstruct this coronoid, because that's the most important part of the joint for anterior stability. One can use that. Couple of my complications. The screw which was used longer, simple option is to remove the screw, use a smaller one. Comminuted situation, multiple K-wires used, one of the wires was impinging. That's how it is. Simple solution is to remove that wire. Plus, remember this. So the take-home message is, if there is no articular comminution, tension band wiring or screw fixation is a good option. Technically easy, simple and fast. If there is gross comminution and osteoporosis, plate fixation plus or minus some intra-articular wire fixation buried within the bone. If there is irreparable middle segment, some amount of acceptable shorting and plating seems to be the way to go. Thank you very much. Let's move on to the next talk. Jesse, you are going to speak on coronal shear fractures of distal humerus.
Thank you. Can you see fine?
Yes, yes, you're good.
What I'd like to talk about are these unusual fractures. The first part is there's a variability even to these unusual fractures. It may be one piece, it may be two pieces, it may involve the anterior and posterior aspect of the trochlea, and importantly, it may involve the lateral epicondyle. And we've identified a number of these different patterns, but the fact is that when you're dealing with a lateral epicondyle fracture, you can use that to help in the surgical exposure. I think the question is how to approach these. I found that the ulnar nerve can be a problem with all elbow trauma. So you can use either a medial and lateral approach or a straight dorsal incision that will allow you to go from the both sides of the elbow. The most efficacious way to gain exposure and reduce the fracture, however, is through an extended lateral aspect of the approach. Even if a lateral epicondyle is intact, one can do a osteotomy intraoperatively and allow that to be reflected distally to add into the exposure. But when dealing with a very comminuted fracture, as the group in London, Ontario showed, these are much more difficult and may require olecranon osteotomy. So let's look at this patient, a 36-year-old male, and he presented 2 weeks after his injury. He had limited motion, limited forearm motion as well, and when he moved, he could feel a crepitation in his elbow. This is his presenting x-rays. And the important point is when you see a double shadow of this anterior displaced fracture, it should be a telltale sign that this is more than a capitellum fracture. This is a more involving both capitellum and trochlea. And the advantage of a CT scan is clear. It gives you an idea of the dimensions of the coronal shear. And importantly, if you look at this, this is the lateral epicondyle that you have a sense of that this has been fractured as well. And by eliminating the forearm, you have even a better idea. And realize that this fracture has gone all the way over to the medial aspect of the trochlea. This is the elbow when it presented. I'll take you through a series of slides and then show you the video of the case. This is the extended the dorsal approach. And now we moved over and freed up the ulnar nerve. Importantly, freed it up into the two heads of the flexocarpi ulnaris. Now we moved over to the lateral side and we're elevating here the fractured lateral epicondyle with its attached lateral musculature. And this will be able to be flipped distally to add to the exposure. The hook retractor on top is on the lateral epicondyle and below is on the lateral triceps. By elevating the lateral triceps posteriorly and exposing the olecranon as well, you can begin to hinge open the elbow on its medial side. What you're seeing here is where the lateral epicondyle was fractured. Up here will be the coronal shear fracture. And the important teaching point that I learned is often the posterior wall of the distal humerus has been impacted. In order to get a more anatomic reduction, you may have to disimpact that. And here we've put back the coronal shear, held it temporarily. But if you look at the gap here, that's because the posterior wall has been disimpacted. If you can't get an anatomic reduction, what happens if you apply compression screws, it will actually shear the fracture off of its base and it may not heal very well. So that's where that disimpaction was done. So now we'll look at the same case through the video. We're freeing up the two heads of the flexocarpi ulnaris, and we moved over now to the lateral side. Here's the lateral epicondyle with its attached lateral musculature, and it's being elevated up off of the lateral triceps and anconeus and displaced distally. So that's the first part. And remember, if you're really having trouble and it's not fractured, you can do an osteotomy of the epicondyle. Now we see the coronal shear piece in the anterior aspect of the elbow. And now we're elevating the lateral triceps and mentioning again the need to disimpact this posterior wall in order to get a better anatomic reduction of the fracture. You have to do this slowly and don't hesitate to make sure that you've got a anatomic reduction. Otherwise, you may not have a very good internal fixation. So we have to do this sometimes 2 or 3 times. Now the K-wires are temporary, and because we can hinge open the elbow, we can get access to the very medial aspect of this coronal shear fracture. And once that's achieved, and having this headless screws in slightly different directions, you can avoid a shearing of the fracture. I like to use double tension wires to bring this fracture back, sometimes adding a plate or not. But tension wires are very good. Inserting them in Sharpie's fibers of the lateral musculature attached to the lateral epicondyle, and then using a double of these, like you saw in the olecranon, will give you, I think, very good fixation of this. And it's a very low profile. So that's being done, and it's we get a stable fixation. Sometimes we put a plate on. I think in these cases, we weren't so happy with it and took it off. But it's very important to repair that rent in the lateral soft tissues and make sure there's no impingement in the operating room. And here's the postoperative image. And here's the image at 2 months where it's healed. He hasn't regained full flexion, but he's got a functional range of motion. And I'll show you quickly one more case. This is a general surgeon who walked into the OR when I was working and said, I busted my elbow. And here we're freeing up the ulnar nerve again on the medial side. And he also had a lateral epicondyle fracture that we're displacing it distally. And this gives you an idea of what you're dealing with. It's totally devoid of soft tissues. And this also shows you the difficulty in reducing this unless you've disimpacted that posterior wall. So once we put this back and use the multiple headless screws, it's reasonably stable per se until you replace the lateral epicondyle and the soft tissues that will add to the stability of the fracture reduction. This is some bone paste in the defect area. And now by bringing back the lateral epicondyle, we can restore the soft tissue stability on the lateral side. So here comes a lateral epicondyle, and that's stabilized again with a plate and screws and tension wires. Again, sometimes the plate seems to be okay, but the screws are not in the best position. So I can take that off intra-op. But here you see his post-op film and his post-op at 3 months range of motion. So I think I've seen ulnar nerve problems with this, loss of fixation. Stiffness, unfortunately, is all too common because these are very difficult injuries, and even deformity. These can be difficult, but always be aware if two shadows means it's not just a capitellum fracture. There may be a progressive complexity of these injuries. 3D CT is really important. And this extensile lateral approach, elevating the lateral triceps and hooking open the elbow will be very helpful per se. Thank you very much.
Thank you, Jesse. Tanna sir, you are ready to go?
Yeah.
Please show us your video on the elbow.
This is a 9-year-old child, which is with an elbow dislocation, which is something very, very unusual. As you can see, this is how he came to me. This was a 10-year-old child with a fall 5 days back when presented with a complaint of pain and swelling in the right elbow. Initial X-ray showed a posterior dislocation, as you can see very here. Elbow was initially reduced and immobilized in a plaster. And I took over at this stage. This is the stage, as you can see, the head of the radius, which has been fractured out, has come out onto the medial side. This is how I saw the child. The elbow was reduced. But when I saw the child, obviously it was a dislocated elbow with the fracture of the head of the radius in a 9-year-old or 10-year-old child, which had to be operated upon. This is the CT scan, which is seen very well, showing the anterior-medial displacement of the head of the radius. I've been through the literature, and I found already about 11 to 12 cases in the children having the fracture dislocation. But I'm not sure whether that's right or wrong. Here is, I saw the stability-wise. This was very unstable. As you could see, it could be reduced, but it was a very unstable fracture. So obviously, I had to now proceed. And here it is. The radial head was extracted through the anterior medial approach. The coronoid process and the medial collateral ligament was assessed through the same approach. The MCL, medial collateral, was noted from the sublime tubercle It had avulsed, but the coronoid was intact. And here you can see there is an imperial collateral is completely loose there, and that is how we proceeded further. Now here is the head of the radius, which was put back, and it was temporarily stabilized with the K wires. So then next one, the head was stabilized with K wires. I wanted to know whether it is going to be in a good position or no. And then once it was stabilized with K wire, I put in the Herbert screw, as you can see, and I am checking it up whether it is a stable construct or I need to put another screw. Being a child, I wanted to avoid minimum implantation, whatever I could do. It was very good. So now again I saw under the SIA that the head of the radius was very well stable there. In supination, pronation is not moving at all, and it was lying very well. So once having head has been fixed up, now the question was of the MCL. So I went on the medial side, and here you can see the MCL, the avulsion side of the MCL was identified and held with two ethibond sutures passing through MCL, and it was sublime tubercle. Now it was fixed up there, and then I'm trying to paste it up, whether the suturing it up makes any difference. Now here it is, as you can see, at the moment it is not tightened, and so the elbow is dislocating it out. And once I will tighten the ligament, then the stability will be achieved. I'm trying to tighten it now. This wasn't tight enough, as you could see, so it wasn't good enough. Then once I crossed the two wires, once I crossed it, and now it was firmly tightened, and then I again checked for the stability. And it was very good, stable in both flexion and extension. And so once this MCL, mainly it is the anterior fiber of the MCL, which needs to be sutured. I have written this article also that when the head of the radius is displaced and the elbow is dislocated out, MCL is always gone. And if you have the head of the radius, even if you replaced it or repair it, quite often needs the MCL repair. So here it is, I sutured the MCL. After completion of this fixation on the table, stability of the elbow movement was confirmed. It is absolutely stable. And you can see here, it is the lateral side, this is on the medial side, MCL suturing. This is what was done. And so now, after the whole thing was done, I wanted to reassess. It has to be against the gravity. And you make this elbow straight, I have done it, and still it is stable. I'm trying to push the elbow back, as you can see. It's not moving, so it's a very stable construct. So in a Siam, once I was convinced that it is a stable construct, now the closer occurs. And this is the patient after 3.5 months. This is the CT scan after 3.5 months. As you can see it very well over here. And this is at the 1 year. He has a range of movement. And there is a supination pronation also. He has got this much. But there is range of movement and supination pronation is obviously not complete. Probably at one stage, if ever it is required, I'm hoping that we may need a head of the radius excision, and we may be able to do it. My feeling is that if the head of the radius is fractured, like this is another doctor friend of mine whose head of the radius was fractured. Obviously, there was the elbow dislocated, and the option was for me this was being irreparable to do the replacement. And these are the CT scans which is there, which I felt was not very, I wasn't very happy for replacing because I find the results are inconsistent. So here is the head of the radius which was fractured, irreparable head of the radius which was fractured. And here you can see the MCL was completely gone here. You can see this is onto the median side, and there is a marked instability which you can see it over here. So in these situations, when there is a marked instability, I felt that only the head of the radius is gone, the coronoid is not gone. The coronoid is not gone. On the medial side, I went there. And on the medial side, the whole medial complex was detached. You can see there is a whole complex situation. Medial was complex situation, and anterior MCL part of this anterior was gone. The head of the radius was gapped. So I sutured onto the medial side all the flexor tendons, and I sutured the anterior fibers of the MCL. Having sutured that, the whole thing was completely sutured onto the medial side, and having sutured the medial side, I checked it up, whether this is moving and whether this is stable or this is not stable. If this is on the table, it was moved in and it has been perfectly stable. No LCL was sutured, only the MCL was sutured, and this is the one which carried on. And I felt that this is good enough. And so this is the patient whom I saw, being a doctor friend I know very well. This is that immediately. This is the one which he had. And ultimately he has a full range of movement, with supination, pronation, and everything. So I feel, I've written about this also, that if there is a head of the radius alone is fractured with a dislocation, if the choice is to replace it, which is the inconsistent results, then you can excise it and suture the MCL. And here I have done that, and that is the one which has given me a very good result. And the last case which I'll show here is, this is the patient which was originally treated by somebody with the olecranon fracture, elbow dislocation. They treated only the olecranon fracture, didn't do anything to the head of the radius. And when he came, there was already a dislocation with the fixed of the head olecranon, which was also not fixed. I confirm it is dislocated out, as you can see very well here. And then this wire was going onto the radial side, and it was hitting onto the surface of the radius. And every time we try to do the supination pronation, you will be hearing the click, because this wire was hitting the radius. This is what is olecranon fixation, which has been advised that you go onto the ulnar side and not on the radial side. Having gone there now, this was the head of the radius which I saw. Fortunately, it wasn't bad, and it was there. So I just put in the wire and elevated it and made it straight. It was reduced. So it was compressed so much, it was reduced, and ultimately you could get the thing that, in spite of such a bad injury, I sutured the LCL, and I sutured the head of the radius, and I sutured the MCL, and then ultimately you having a good result for that. So I feel if we treat the elbow dislocation properly, then you are expected to get a good result. But the results of the elbow replacement, the head of the radius replacement, it is not consistent, and that's the reason I am a bit hesitant. But quite often I still do the head of the radius replacement as it has been done over here. This is the head of the radius was replaced, and then I'm suturing the LCL. After suturing the LCL, I confirm back, and the elbow is not still stable. Still is not stable, so I went and sutured the MCL. Once you sutured the MCL, now the elbow was seen, and now the elbow is very stable. This is what is the one which I feel that you got to do this. Everything, whatever you need to do at one time, you got to do this. And I feel now I think my time is over, so I'll end up at these things. Thank you very much, friends.
Thank you, sir.
Sushrut, you are there, no?
Jesse, you want to take your talk on
Yes.
non-union please?
Yes, stop sharing. He should stop sharing.
Yeah, I have stopped sharing already.
Okay. No, it's not working. it's coming up your talks.
I have stopped. We can see you on the screen.
If you see when I go.
Okay, I'll go out and I'll come back.
Okay, thank you. Try again. No. It doesn't seem to be letting me get on. I'm seeing again you.
I already gone out.
Sushrut, can you fix it up?
Let me just see. Akshat. Let me.
I'm not sharing.
Wait a minute.
Well,
No, wait a minute. I will share my screen.
okay, let's do this. You have my talk then?
Yes, that's what I'm trying to open now. All right.
Okay. All right.
My second talk is on non-unions of the distal humerus. If you look at this X-ray, there's a supracondylar level failure of fixation and a very unstable non-union that's painful, associated with an ulnar neuropathy, and it's a dominant limb. In many of these cases that you want to obtain internal fixation and fix the components, it involves ulnar nerve neurolysis. I prefer an electronosteotomy if I can do that, especially the supracondylar level. And you have to debride not only the non-union site, but release the capsule, both posterior capsule and anterior capsule, and internal fixation. In some of these cases, the anatomy is not quite like a fracture, and you may have to be a little bit creative in the fixation. So if we look at this case here, and we're going through the previous incision, and here you can see the ulnar nerve is encased in scar. If you don't free up the nerve 6 centimeters proximally and distally, you may get a traction neuritis when you're starting to move postoperatively. Because the elbow joint itself hasn't moved, the motion has been in the non-union side, you have to be careful elevating this osteotomy because cartilage can stick together. And in this particular case, you can see the osteolysis and the debris of the metallosis that's present. All that has to be removed, and this is the distal fragment that's been elevated off both the posterior capsule and the anterior capsule that's done through the non-union site. There often is little space for bone graft per se, so we'd like to get a good contact with both pieces, and in this case I've used 3 plates, again because the anatomy was abnormal. If the fixation is good, we like to get the patient moving with gravity assist, letting the arm go over the head and gaining flexion by using the other arm and just gently allowing gravity to do the work. And he was his postoperative healed range of motion. So at the supracondylar level, remember that you want to get a free capsule anterior and posteriorly and get a good bleeding surfaces of both sides. And here you can see the creative use of wraparound plates because of the anatomy is not quite normal. and this is that patient range of motion. Sometimes you actually have a defect in the cartilage alignment of the trochlea, so this has to be osteotomized as well. And this is this patient's range of motion. Here's another case, and this is an older woman, but if you can restore, and again, the 3-plate technique, you can get a good fixation, and once again, a good range of motion. Rarely, but you may see an intra-articular non-union that's solely an intra, and a little bit like the coronal shear, where there's very little soft tissue attachment. So I
think you not working now.
Like both surfaces, and compression screws, we can get back a stable fixation, although his extension was less than optimal. Rotation was good. There are some times where you see a very small distal fragment. The reason it's very small is because the anterior capsule is contracted and it's pulling down that fragment in flexion. That's why a CT scan may be very helpful. And here there was sufficient bone to actually create a fixation point, shaping the end of the proximal segment of the humerus into kind of a V and inserting it into the distal fragment. We saw some cases of combined non-union of the olecranon osteotomy and the non-union of the humerus, and it requires a good deal of debridement. If you notice, the cartilage surface doesn't look very robust, and that's because it's been covered with granulation tissue, because there hasn't been motion there. But cartilage remains viable, and if you can free up and regain motion, then that would likely be a good joint. You may find that in elderly patients, infirm patients, or something that's non-reconstructible, like in this patient, that a total elbow is a very efficient way to do it. Very seductive because the motion will be regained very quickly. So in conclusion, I would say it's very important, if you're trying to get fixation, that an anterior and posterior capsulectomy be done. Think about the ulnar nerve, because if it's a post-traumatic non-union, it's likely to be in scar. And think about fixing the fracture rigidly, but you may need to do more than 2 plates, but then rapidly rehabilitate. We've had some patients that have come in with infected non-unions, and they were pretty early on in the course of treatment. And if the joint seems to be salvageable, it doesn't look very good because of all the granulation, but by debriding it and applying an Ilizarov with the olive wires, bridging back the distal fragments and going into the proximal with the half pins, we can get these patients actually moving through this frame, and this patient healed with a reasonable amount of function. So I thank you very much.
Thank you. So, Mike, do you want to take your talk? The most important idea to maximize success in distal humerus fractures.
So I'm going to share my screen here.
Yeah.
Put this up. Can you see that okay?
Yeah, you're good.
We're good? Okay, great. So I'm going to talk briefly about how to maximize outcome and success in the treatment of these difficult fractures. The whole goal of this talk is to avoid the situation you just saw Jesse speak about. He makes it look easy. For most of it, it's very difficult. So if at all possible, prevention is the key to ending up with one of those bad distal humeral non-unions that Dr. Jupiter just spoke about. So I'm going to go through 6 points. Number one, if this fracture is open, 90% of the time there's a wound in the posterior aspect of the elbow, and there's a big hole in the triceps you can incorporate into your approach. And so this is a patient who fell off a roof and has a significant open distal humeral fracture. You can see that the shaft is poked out through the skin. You can see the air and the soft tissues there. And in adults, not in kids, but in adults, 90% of the time in this kind of situation, the wound is posterior. If the shaft made a hole in the skin, it had to make a big hole in the triceps as well. This is that patient who came in from an outside hospital and was quickly patched up. And you can see we've made the surgical excision there. Now you can see the big hole in the triceps with the shaft sticking out of it. And there it is right there. In that situation, you can use the hole in the triceps in your approach. The corollary of that is if you have an associated olecranon fracture, as you see here, then by all means use the olecranon fracture as an easy access point to your distal humeral fracture. So use what was given for you in your approach. And I'll show you how we did that in 1 second. The second point would be is that if the wound is posterior, it's the shaft that made the hole, and you should focus your debridement there. And I'll go back to this original case. And here's a close-up of the shaft. You can actually see pieces of dirt, and it was actually a couple pieces of the patient's shirt stuck on that shaft of the distal humerus. So that's where you want to focus your debridement. The joint's usually pristine. There's nothing much in the joint. It's the shaft piece, and sometimes even up the canal of the distal humerus, where you'll find dirt and debris. So when you're debriding this, you want to focus your debridement on that specific area. And here we removed a few pieces of this patient's shirt from the shaft of the distal humerus. When he woke up, I said, "Did you wear a blue shirt when you fell off the roof?" And he said, "Yeah, I did." And how'd you know that? And I said, "Well, because some of it was stuck in the distal humerus there." And this is that same patient after we finished our triceps split. So we've taken that big defect you saw in the first pictures, and we've extended that proximally and distally and reflect the triceps completely off the distal humerus. Now, you could argue this particular fracture is relatively straightforward. You might have been able to get away with a triceps sparing or something, but I thought these were good illustrative pictures to show you exactly how you can do this and the exposure you can get. And here we've done this, clean out the distal humerus, and you can see we've actually resected a piece of the shaft that has some dirt and shirt ground into it. And we reduce this and fix it with multiple K-wires. So now we have the fracture reduced, and how do you plate it? Well, I think it'd be safe to say that everyone would agree that bicolumnar plating is a treatment of choice in this situation. And the two main options there are parallel plating as opposed to perpendicular plating, or the old AO 90-90 plating technique that I sort of grew up with and was taught in my residency. And these are some of the options. You'll see none of these options show two plates directly posteriorly. If you look at some of the cases that Dr. Jupiter showed, a common feature was poor placement of the plates originally that resulted in the non-union, especially straight posterior, or that old Y plate that we used to use, right in the plane of motion of the joint, at a high failure rate. So if you look at the cases that Jesse sees that have failures of initial treatment, relatively few had good operative fixation with the bicolumnar plating. These are the options to you: parallel plating on your left, and then two forms of perpendicular plating on the right. Well, which one is better? If you look at it purely biomechanically, you can see that the parallel plating gives you about a 10 or 15% advantage in terms of stiffness compared to the perpendicular plating. And especially in gap models or in poor quality bone, you can get long screws, 30 and 40 millimeter screws across from one side to the other in the distal fragment with the parallel plating technique. That's very hard to do with the 90-90 orthogonal technique. So in general, for these fractures, I like to use parallel plating, which I think allows a little bit better stability, especially in tough cases. For most cases, it probably makes a little difference as long as you're good at one technique or the other. But that occasional difficult case with poor quality bone distally, you're probably better off with the parallel plating technique, which is what we did for this patient here. And you can see that technique applied there. These, the radiographs afterwards, which showed good reduction, and it allowed this patient almost immediate motion, which enhances the functional result. What about the nerve? Well, people talk a lot about the ulnar nerve. So it's mandatory to find and protect the ulnar nerve throughout this case. You have to find it, you have to isolate it, and you have to protect it throughout the case. But what happens at the end? Do you transpose it or not? And I think both Dr. Jupiter and I have gone through a number of different periods where we always transpose it, sometimes transpose it, blah, blah, blah. Really, there's a lot of opinions on, but not a lot of science. What do you do with the nerve? So this is that same case. We've sewn up the triceps here and have the ulnar nerve. Do you leave it there? Do you transpose it? What's better? Well, we did a study with the Canadian Orthopaedic Trauma Society of almost 60 patients with this exact injury, randomized 31 to decompression of the nerve alone and leaving it in situ, and 27 had decompression and anterior transposition. Mean age was 52. There was a good distribution between the two groups. The two groups were the same, and the randomization schedule worked pretty well. To make a long story short, this slide sums it all up. It made no difference whether you decompress the nerve or whether you transpose the nerve. What is interesting is that a normal score here is 9, and you can see a significant number of individuals had a lot of discomfort in the ulnar nerve all long-term after this injury. So we haven't solved this problem yet, but decompressing it alone versus decompressing and transposing at the end of the case didn't seem to make much difference. But what you can expect is a lot of patients have some residual ulnar pathology. So we're still looking for what the right answer is here to try and minimize this ulnar nerve pathology, which is common. So now when I see these patients, I tell them right off the bat, you're going to probably have some numbness and tingling in these fingers long-term. Hopefully we'll get better with time, as it did in most people, but still is an issue in these patients. And the Mayo elbow score was the same. Didn't make any difference to elbow scores. Most patients had a good result, around 90 or so. What about total elbow arthroplasty? Jesse talked briefly about that for the treatment of patients who had non-union. For the comminuted C3 fracture in an elderly female, a TEA is a better way to go and has good longevity. And so I'll show you another randomized trial we did looking specifically at this fracture. So it's not for everybody. It's older patients, C3 fractures, multiple articular fragments. Like this patient here, that patient does better with a TEA. And there's good evidence to support that. These are the Mayo elbow performance score, which is better in the red group or the TEA group. It's better at every time point, and it's better long-term. So we know these patients do well with a TEA. And this is the categorical rankings. And you can see you can give someone often an excellent elbow with a TEA. It's very hard to do that in an older person with fixation. Here's the kind of busy slide, but it shows how we randomize these patients. And if you look, you can see that intraoperatively, 5 patients switched from the fixation group to TEA group. But what I want to focus on is the long-term outcome. These patients were an average of 79 years of age. Almost all were female. Very few had any revisions. Most of them died with their elbow in place and functioning well. We only had 1 revision in those 25 patients. That was early for infection. So in general, the long-term outcome was very good, and the failure rate was very low for this specific patient population. And the last thing I'll say is that occasionally, keep an open mind, you'll see a patient with pre-existing arthritis in their elbow. When they fall, if you ask them, was your elbow sore and painful before, and they say yes, there's no point in just fixing the fracture. You should take this as an opportunity to make them better with the elbow arthroplasty. This is a patient with long-standing rheumatoid arthritis, painful stiff elbow, a couple failed operations. Then she fell and broke it, and she was ecstatic with the TEA we did for her. So always keep that in mind if you see patients with pre-existing pathology. They do better with replacement than with fixation. Thanks very much for your attention.
Thank you. Let's move to the next talk. Jesse, you're ready with contracture release of stiff elbow?
I think you better show my talk. Okay.
Oh, you want me to do that?
Yeah.
Sure.
I can't, something happened to my screen sharing.
No problem. All right.
That's
All
it.
right. Jesse.
Good.
So now we'll talk about the operative approach to the stiff elbow. And these are my disclosures from all the associated activities. Whatever the problem you're dealing with, whether non-union, heterotopic bone, whatever, contracture is part of these problems. And a definition of a contracture might be where it's been at least 4 months, there's a firm endpoint, there's no active inflammation, and the patient hasn't gained with therapy. Intrinsically, there may be a non-union, malunion, but there'll always be intrinsic scarring of the capsule. Extrinsically, you may see not only the problems within the joint, but bone and outside of the joint itself. We don't really know what causes this, but I'll just give you an insight that there's a lot of studies ongoing to try to understand why joints get stiff and what happens that makes the myofibroblast so active in these cases. Preoperatively, remember that always think about the ulnar nerve, define where the heterotopic ossification is, and consider how much functional disability there is. But if patients have spasticity or unable to cooperate with rehab, it's probably not a good idea. The operative protocol for capsular release is, in a way, somewhat reminiscent of the same approach we need to deal with in non-unions. On the lateral side, particularly patients who have had radiocapitellar pathology, the lateral column procedure is advantageous. It's simple, limited morbidity, and you have good access to the anterior and posterior capsule. But if there are a lot of problems medially, it's a difficult. So here's a patient who had radial head fracture and developed considerable stiffness. This is in surgery now. So we go through an extended lateral approach, approximately on the lateral border of the humerus, and distally following the lateral triceps and anterior musculature. And we're now elevating posteriorly, and that's posterior radiocapitellar joint. By elevating some of the lateral epicondyle area of the triceps. And here this patient had considerable amount of loose bodies as well that we can take out. Going posterior, we're going posterior to the humerus by elevating the lateral triceps. We can free up sufficiently to get to the posterior capsule. And what we see here, that's the proximal tip of the olecranon, and we're elevating the posterior capsule completely and deepening the olecranon sulcus in the distal humerus. So we can observe that there's no impingement distally. In the anterior aspect, that's the brachioradialis and radial wrist extensors arising from the lateral epicondyle. We've elevated that up partially, and here you're looking at the lateral aspect of the capsule. Removed additional loose bodies, and we can take a vertical capsule to breed a little bit of the coronoid fossa so that there's no impingement of the coronoid, and then check the rotation as well as the flexion extension. And here we see in the OR, you'd like to be able to get full flexion extension without forcing the issue, per se. On the medial side, when you have the indications may be a severe contracture associated with ulnar neuritis or extensive heterotopic ossification, it gives you excellent exposure, and you can get to the ulnar nerve as well. But if you have additional problems on the lateral side, it may not be complete. So here's a patient who had trauma, and she has reasonable flexion, but a very stiff extension deficit. So this is a medial approach bordering on the medial part of the humerus. And that's the flexopronator group. There's your ulnar nerve, which we have mobilized. And we'd like to keep the medial intermuscular septum intact, which is being held right there. So that will prevent the ulnar nerve from subluxing when we start motion. So we've elevated a little bit of the medial triceps, and we're going to the posterior medial aspect of the joint and freeing that up and freeing up the capsule that's contracted in the olecranon sulcus will help gain better flexion and extension as well. Again, deepening the olecranon fossa slightly. Now we're going to go anteriorly. We've left the medial intermuscular septum intact, and there's the flexopronator group. So we'll make what we call a hockey stick incision, and we've split some of the flexopronator muscle, and we're elevating up the anterior musculature off of the humerus as part of the brachialis, and we'll that's the capsule. So we split the flexor pronator where that retractor is, and we're elevating the capsule. And you can appreciate the thickness of this capsule as well. And we can free this up all the way over to the lateral side of the humerus. And we've kept the ulnar nerve away from the surgical site to avoid any injury there. Bring up the capsule, and once again, you can appreciate how thick this capsule is. Freeing up a little bit of the coronoid fossa, and one can watch inflection extension. There's the coronoid going over the trochlea, and now she's regained intraoperatively at least a full extension. Posteriorly, going on both sides of the elbow, when you have not only severe contracture, but heterotopic bone that's surrounding the whole humerus and joint. And the way to the front of the elbow is through the sides. Arthroscopically is now being touted by a number of people, and you can get a better visualization, but one has to start with a very simple contracture, because it can be a little bit difficult, and it certainly involves some risk of the nerves on the radial side and the laterals on the medial side as well. Posteriorly is a little safer, so debriding the posterior capsule is probably a much safer approach. And medially, in the medial gutter, is where the ulnar nerve lies. And many people believe we should do an open release of the ulnar nerve, per se. What's moved to post-op recently is not only the active motion, but is adding doxycycline, as an inhibitor of MMP3, and oral prednisone as an adjuvant as well. So in summary, capsulectomy is a good option for restoring motion, but sometimes it requires more than one surgical procedure. And diminished elbow function may be related to stretching of the ulnar nerve. And I think we found that it's a safe overall and effective procedure. But understand the nature of the problem, and there's often more than one situation. It could be involving inside the joint and outside the joint. And if the joints are okay, then the results seem to be better, per se. Thank you very much.
Thank you. My first question to you, Jesse, immediately is, you were very categorically saying that you do not touch the medial intermuscular septum. Do you do that also when you fix the distal humerus as well? Because of the fear of ulnar nerve subluxation, you say. So is that your take also in...
As Dr. Mckee pointed out, whether you leave it in situ, so to speak, or move it or transpose it, maybe doesn't matter per se. However, I think the problem that comes about from the ulnar nerve is a failure to mobilize it sufficiently. Because in a lot of the reconstructive situations that I've dealt with, patients tend to have constriction of the nerve in moving as it goes into the two heads of the flexor carpi ulnaris. So I've always been very careful to try to mobilize the nerve, preserve the motor branches. But by doing that, in essence, it will sit in the soft tissues. It will be a transposition of sorts. But if you mobilize it sufficiently proximally and distally, I don't think you'll see the problems later. I've also found that patients who have done well initially, you fix the fracture, everything is good. They're very cooperative and working hard to regain their motion. there's a group of patients that will slowly deteriorate over 4, 6, 8 weeks. And if you carefully examine it, the problem is the ulnar nerve. And they've developed what's, I call it, secondary traction neuritis. And that's because the nerve is not moving sufficiently. So I think I would err on the side of letting the nerve mobilize itself rather than a formal transposition or leaving it what's so-called in situ.
Sure. JC, I asked you last year also this question, and when we met at Davos as well. So what's your take today on parallel plating versus perpendicular plating?
There's a lot of advantages to the parallel plating, especially with more osteopenic patients per se. The concern I've always had with the parallel plating is on the medial side, and that if you have to strip off too much musculature to put the plate on, I think it may retard healing. So I think the problem is really, as Dr. Mckee pointed out, the C3 fractures. And I think you get better fixation with parallel plating per se. But frankly, I think I still believe there's a role for making your own fixation using reconstructive plates or whatever, and you can be more creative in those very low distal fractures, even 2, even 3 plates as well.
I'll tell you what Indians think. So since 1990-91, since the article has appeared on perpendicular plating, we have been following God of the elbow called JC Jupiter, and of course the fashion came of parallel plating, and now we think that since the clinical results are much similar, except for extremely low fractures, which is maybe 15, 20%, 25%, the role of parallel plating is very, very minimum, number one. Number two, Indian bones are smaller bones. So typically internationally available anatomical plates don't fit very snugly on the bone. They tend to be more proud than what they are designed to be, low profile. So in fact, we are back to JC Jupiter teaching of perpendicular most of the times, 10-15% times parallel plating. Mike, you are itching to say something, so I can see that. Please, Mike.
No, I agree with what's been said. I think you should learn I think they're both good techniques. I think you should learn a technique and do it well. I think that one time, 90% of the time, it won't make any difference as long as you do it well. 1 time in 10 with osteoporotic distal bone and a very distal fracture, I think the parallel plating will bail you out of a tough situation that you would not do well with perpendicular plating. So I'd agree with everything that's been said, frankly.
Totally agree.
I'd also say, having designed some elbow plates, that trying to make a single set of plates that matches, a 300-pound North American male and an 80-pound Asian female is extremely difficult. And that's something the companies, I think, have not been in tune to in the past and need to be more cognizant of going forward, that there are significant differences that need to be addressed when we design plates, and one size doesn't fit all. And I'm actually glad to hear you say that, because I'm going to use that as ammunition to try and get better plates designed for everyone, not just one sort of population, which is the basis for most large companies right now.
Absolutely. Thank you. I must take Indian votes here. Tanna sir and Kotwal sir, your take on this parallel versus perpendicular plating. Let's get this straight. Tanna sir.
Having tried the parallel plate, mentally I think you are not very comfortable unless you've done the leg screw into the intra-articular fragment. And that's the reason in the parallel plate you are not supposed to do the leg screw, but all the screws are supposed to go in front. And I found it not to be really required majority of the times. So hardly ever I do a parallel plate.
Kotwal sir?
Actually, it depends upon the situation, the fracture configuration and all that. But nonetheless, actually, I prefer to do a orthogonal plate rather than doing parallel plates. That actually I find it better placement of the plate on the lateral part of the lateral condyle. In that way, it facilitates the fixation.
There's a question for you, Mike, from Dr. Sitaram Rao, a colleague of mine. In elderly osteoporotic C3 fractures of distal humerus, when do you time total elbow? Within 1 or 2 days, or wait for a week for soft tissue swelling to reduce?
There's no real evidence to support doing it early or late. It's probably, for me, dictated mostly on logistics. If I see the patient from my own ER, I'll do them the next day without a problem. If they get referred in from somewhere else, typically I'm doing them at 1 or 2 or 3 weeks. My experience has been there's not a lot of difference between the outcomes amongst the two. In an elderly patient that I do an arthroplasty for, I'll often splint them in some extension just for the soft tissues alone, let them heal. And I almost never take off the triceps in this situation. We didn't talk about technique too much, but you can do a TEA for a fracture by excising the distal pieces. That gives you a working space, stem up, stem down, and you never have to take off the triceps. And I think that's critical for these older patients, so you don't have to do that. And then your soft tissue is much, much better protected at the back. And I sometimes splint them in extension for a while if there's a major issue there, just to make sure we don't lose soft tissue.
Okay, another colleague of mine, Dayanidhi Desai, is asking if implants need to be removed, any role in improving the post-operative range of motion. Jesse?
I think that if you're looking to do that, the problem is the contracture of the soft tissues, the capsules and ligaments. So removing implants and trying to get motion has a certain risk that you have empty screw holes as stress rises as they're vigorously regaining their motion. So I wouldn't do both together normally. I would try to get motion and then remove the implant if it's bothering the patient, or remove the implant alone. But I've had seen some patients who had rehab after plate removal and mobilization fracture through the screw holes.
Yeah.
If I could address that briefly. So
yes,
we actually, I learned a lot about this from Jesse, and we actually published a paper. It's an injury last year looking at 50 patients who had bicolumnar plating for a distal humeral fracture, who came back for have a revision done. And these weren't revisions for non-unions. These were stiffness, hardware prominence, and ulnar nerve pathology. That's the 3 big things. So not the distal humeral stuff Jesse was talking about, that's completely different. But if they came back, healed fracture in a good position, but they weren't happy with their elbow, their 3 main complaints were stiffness, hardware prominence, and ulnar neuropathy. And when we did them, we generally speaking waited a year at least for the fractures to heal. We did take both plates out at the same time in general. And there's a very specific surgical sequence you go through. So you do the capsulectomy, you free up everything, and then you get the elbow moving before you take the plates out. You don't want to manipulate it after taking the plates out. Then all the hardware comes out. Those patients, and we release the ulnar nerve pretty well every time. Those patients had a pretty gratifying return of function, so that most were very happy with the operation. We gained about 30 degrees on average, and most of the irritation from the hardware went away. What wasn't as consistent was the ulnar nerve. So ulnar nerve pathology persisted in a number of those individuals. So if they come back with that problem, you can say, well, take your plates out, release your elbow, release the nerve. You'll get better motion. The prominence of the plates will go away, but the ulnar nerve may or may not come back. And I think that's a good article to read if you're interested in this. It's an injury last year.
Yeah, thank you, Mike. That's great. To elaborate more on this stiffness business, doxycycline for prevention of fibrosis. Jesse, you made some remark on that, use of doxycycline.
Yes.
So can you elaborate on that, please?
The Mayo Clinic has been doing a lot of work having a joint stiffness model and looking at various adjuvants that affect the capsular stiffness. And doxycycline or that type of medication seems to inhibit certain factors that were seen very commonplace in these contractures. It doesn't have to be doxycycline, that's an antibiotic, but those in that same family. And prednisone also being added IV during surgery and then for 5 days also seems to be very effective. And so the results now would lead us to use both. It's a little bit of lack of absolute science from patient to patient, but it seems to be based upon scientific evaluation in models.
Tanna sir, do you have any trick up your sleeve for stiffness that you add, some medicine or some magic material there?
No, we've had, oh, go ahead.
You unmute, please. Tanna sir, unmute.
I have a question for Professor Jupiter, whether this steroid given for 3 weeks is to prevent ulnar neuritis or to prevent heterotrophic ossification, recurrence of the HO mass.
It's really for the capsule, the capsular contracture, neither for the nerve or heterotopic ossification.
Allah sir?
I have one observation about the stiffness of the elbow. In a non-union setup, so many times pre-operatively we see that the elbow is moving, but that is moving at the non-union. So I have always I have made it a rule that in a non-union setup, when we fix it up with two plates and screws and the grafts and everything, at the end of a good fixation, you got to move the elbow. And we realize so often that the elbow doesn't move. And if that elbow doesn't move immediately on the table, then I think you will have to go ahead and do a completely release of the soft tissues to get the elbow movement. Otherwise, that implant is not going to hold, and you will not be able to get any movement afterwards.
Yeah.
So the stiff elbow non-union is the one which is otherwise very, very tricky, because unless you have checked it up after the operation, you can be trapped at times. That when you start movement, it moves at the fracture site, and the whole thing opens out.
Yeah. Mike, you are saying something?
I was just going to add one thing about the medication thing. So it's a guy named Kevin Hildebrand who works in Calgary, who's interested in a medication called ketoprofen, which is a mast cell inhibitor. So it decreases the amount of mast cell degranulation at various fracture sites, and et cetera. And there's been some promising work done in that in animal models and in a prospective clinical trial. The comparative study is yet to be completed, but it might hold some promise going forward as a medication to stop this stiffness from occurring. And we know that happens to some people. No matter what you do, all these things we talked about, I agree with completely. I've done all those things in some people, and still the stiffness comes back irreversibly. So we're still grappling with who that happens to and how to prevent that from happening. And it won't be a surgical solution. It'll be some kind of medical solution, I'm sure, going forward.
Yeah. There is another quick question by Bismukesh Panigrahi. If there is a non-union, how to position those 3 plates that JC taught us? So 2 plates on the lateral side and 1 on the medial side. We take it, JC?
Yes, most of the time that's correct. On the medial side, if you use a malleable plate, it can be bent around the medial epicondyle. Even these very smaller fracture fragments distally still have a medial epicondyle, and by bending it around there, you can put the 2 distal screws somewhat perpendicular to each other, and it gives you more stability. And I would agree about that stiffness. That's why before doing your internal fixation, through the non-union, you should be able to debride the anterior capsule. And the posterior capsule comes off when you elevate your exposure, but the anterior capsule, you should do very well through the non-union site before reducing it.
I take this last question from Arijit Mandal. He is asking for extra-articular distal humerus fracture. The lateral plate that we use, one plate, is that enough? Tanna sir, you want to take this?
So I think I like to put 2 plates, extra-articular, which is, we are talking about the lower down.
Correct.
So it is not intra-articular, but it is a distal fracture. 2 unequal plates is the one which I like to do it.
Okay. All right. So let's move on to the next session. May I request Dr. Prakash Kotwal to speak on malunion distal radius. Sir.
Sure. I'll share my screen. Can you see my screen?
Yes, you're good. You're good.
Okay. Thank you very much. Good evening, everybody. I would like to thank Sushrut for giving me an opportunity to speak on malunion distal radius. The malunion is defined as shortening 3 millimeter and dorsal tilt of 10 degrees. It is quite common, as we all know, and the reported incidence of the malunion is anything from 27 to 60%. The presentation is pain, loss of motion, and that depends upon the direction and magnitude of the deformity, cosmetic deformity, decreased grip strength, and later on arthritis. The pain at the fracture site is generally rare, not so common. The pain may occur during the wrist movements. That's maybe because of the stiffness of the wrist. The ulnar-sided wrist pain is more common. And of course, the pain also can be due to median nerve compression, carpal tunnel syndrome, and sometimes the onset of CRPS. The ulnar-sided wrist pain is because of the fracture of the ulnar sternite, which may not have united properly, injury to the ulnar collateral ligament, ulnar abutment syndrome. As you can see on this X-ray, the ulna is abutting against the carpals, TFCC tear, and DRUJ instability. The malunion can be extra-articular, dorsal, volar, or radio-ulnar, or it may be an intra-articular malunion, as you can see on this X-ray, or it can be a combination of these. The payoffs of malunion are the malunion affects the radiocarpal, midcarpal, and radiocarpal joints. It increases the stress at the dorsal lip of the radius, particularly at the radiolunate articulation, and this has been proved by a mechanical study. The immediate functional impairment can occur due to shortening of the radius, loss of grip strength, loss of motion at the radiocarpal joint, and late sequelae of osteoarthritis. The evaluation actually includes the X-rays, the CT scan, MRI, and orthoscopy, and actually this gives the idea about the intra-articular or extra-articular malunion. The malunion can be symptomatic or asymptomatic. This patient, an 82-year-old lawyer, a 60-year-old fracture, but has a functional range of movement. So the bottom line or the caution is that we treat the patient and not the X-ray. The treatment guidelines, the exact indications are ill-defined. However, this is certain that we treat a symptomatic malunion only. And that symptoms can be because of the DRUJ, or the midcarpal pain, or the carpal tunnel syndrome, or weakness of grip strength. And also always rule out CRPS or RSD, which can be diagnosed by stiffness, swelling, change in the color, temperature, and so on. And it can also be diagnosed by a radioisotope bone scan. As you can see here, there is an increased uptake. We have a publication to this effect about the work on the diagnosis of RSD with the help of radioisotope bone scan. The osteotomy can be either dorsal or volar or multiplanar, and actually it needs a fixation and bone graft depending upon the volar or the dorsal approach. The dorsal angulation, as you can see here, is treated by a dorsal approach and a dorsal plating. In fact, dorsal plating, this is one of the major indications of dorsal plating in distal radius. Then, even if the angulation is dorsal, it can still be treated by a volar plating with the help of the plates, newer plates. And of course, a volar angulation in a malunion can certainly be treated by a volar plate. Then sometimes you require salvage procedures, and actually for a long ulna you need ulnar shortening or Sauer-Kaplan-G procedure. The ulnar shortening, there are various procedures: the direct procedure, the wafer resection, and ulnar shortening. And for example, in a situation like this, you can do a direct procedure. However, the direct procedure is these days is not considered a very good surgery because of the instability that it leads to, and which may require the stabilization of the stump. And therefore, it is not recommended in young patients, and perhaps may be useful only in older patients with rheumatoid arthritis. So for a situation like this, one may do a direct procedure, but that requires stabilization of the distal stump of the ulna with the help of some tendon graft taken from the extensor carpi ulnaris or the adjacent tendon. And for example, this is the one where these holes have been made to stabilize it using a tendon. However, the another procedure is ulnar shortening that you can do with the help of with the plates, or you can also use the modern plates, the distal ulna plates. However, the fracture is united here, but because of the osteoporosis, sometimes the screw gets loose and then they need removal. Wafer resection for some ulnar positive variants here, which is abutting against the carpals. One can remove a very small wafer of bone subchondrally and can lead to this neutral ulnar position, and without the need for implant fixation. Another procedure which is done sometimes is the Sauer-Kaplan-G procedure for this, and particularly is indicated in the osteoarthritis associated in the sigmoid notch. You remove a segment of the ulna and fuse this radioulnar articulation at the distal end. So this gives good results. As you can see here, there is the rotation and the flexion and extension possible. And I am grateful to Dr. Sudhir Vallier. This was the patient who was operated by me about 12 years back. He ended up with him recently for something else, and he sent me this photo. The patient has really good range of movement. Now I'll quickly go on to a procedure of the Sauer-Kaplan-G procedure. This is another case where there was, you can see here, there was an degenerative changes and instability of the DRUJ joint. And on the ulnar side, on the just beneath the radial ulnar styloid, you make an incision to expose the distal part of the ulna. And you go on to the distal and try to fix the temporarily with K wires the distal head, the head of the ulna with the distal part of the radius. Mark out 1 centimeter of bone which is to be resected. Decorticate the area of the adjoining areas of the ulna and the radius in the sigmoid notch. Oh, sorry. Then you fix it with a threaded screw, and you can also pass another screw of a smaller diameter to fix the distal radioulnar articulation. Perform the osteotomy of the distal ulna to remove that segment of ulna which you had earlier marked about 1 centimeter or so. This is fixed. Now this is the position with the. Now to stabilize there are various methods to stabilize the distal ulna. One is you can insert the corrector quadratus into this, or take a tendon, as has been done here, a part of the tendon of the flexor carpi radialis, and bring it and suture it, make a hole through the distal ulna and suture it on itself to stabilize the distal stump. Take some bone graft from the segment which you have taken, and maybe you can fill it up into the articulation which you intend to fuse, and then try to close the wound. Check the rotation on the operation table. And 6 weeks post-op, that's the post-op X-ray. And the range of motion, supination and pronation that the patient has, which is pain-free. So to conclude, the malunion of the distal radius is quite common. The majority can be treated conservatively and by physiotherapy. The function should be judged, and it should be acceptable generally, which is generally acceptable. Otherwise, surgery is required in selected cases, and the salvage procedures may be required occasionally. Thank you very much for your attention.
Thank you, sir. Shall we move on to the next talk by my friend Sudhir? Sudhir, are you on?
Yes.
Your surgical video on extra fixation, right?
Yes.
प्रकाश सर तुम्हाला अनशेअर करावं लागेल.
Oh, yeah.
Is the video? Sushrut, is the audio visible, audible?
Oh, no audio, Sudhir.
Oh, sorry. Can I just start again?
Go back again, yes.
I'll just sorry.
No problem.
Why is this not happening? I'm wondering. Let's just give me a second. Yeah. Yeah. All right. I got that. Yeah. Is that good? A crush injury of the thumb.
Yeah.
He presented this idea. Oh, sorry. A brief history of mini external fixation in India. Dr. Vinod Arora was a young resident who used electrical clamps as an external device to treat a crush injury of the thumb. He presented this idea to Dr. B.B. Joshi, who was already experimenting with wooden blocks, plastic material, and dental cement for the same purposes. Dr. B.B. Joshi and his colleagues developed, refined, and popularized the JES fixator. Dr. Lard and his colleagues further refined the system to create the UMEX fixator, or the Universal mini external fixator system that is used in this video. This fixator is based on stainless steel clamp with an inverted teardrop hole for K wires and a knurled connecting rod. This system was tested and found to be over 2.5 times stronger than existing systems.
This is a complex 3-part intra-articular fracture of the distal radius with a dorsal ulnar lunate fragment and a scaphoid die punch. Sustained traction and manipulation afforded an acceptable close reduction of all fragments. Here a wire was passed through the radial styloid and another antegrade from the radius into the lunate to restore the radiolunate joint. Next, we bend the pins at 90 degrees to the forearm, which makes it possible to incorporate them in the external fixation frame. With the forearm in supination, a 1.5 mm K wire is introduced approximately 1 cm proximal to the fracture line to avoid microfractures and pin loosening. While drilling the pin, we prefer a cruciate incision, which provides extension in both transverse and longitudinal plane, which avoids tenting of the skin over the wire. Pins are inserted under continuous cold saline irrigation. The second pin is passed just distal to the mobile ward of Henry, therefore avoiding any injury to the PIN. Now the hand is held with the thumb in maximum abduction and the fingers flexed at the metacarpophalangeal joint before placing the distal pins, making sure that the first web space is fully stretched out to avoid adduction contracture of the thumb post-operatively. Now the 2 metacarpal pins are introduced, one into the metacarpal neck proximal to the attachment of the collateral ligaments, and the second one just proximal to the base, making sure to get good purchase in at least 4 cortices. When required, a mirror ulnar frame may be erected. While preparing the pins for the connecting rod, it is advisable to cut them in decreasing lengths, which makes the rod placement easy. The mini clamps are placed on the connecting rod, which is then threaded through all the pins, including the 2 used to hold the fracture fragments. The varying lengths of the pins makes it easier to introduce the connecting rod without much struggle. While tightening the clamps in the intact segment, gently pre-stress the pin towards each other. Pre-stressing the wires prevents translation of the intact segment within the frame. Adding a second rod significantly improves the stability of the frame. If the wires are not coplanar, An offset of up to 6 mm can be incorporated by flipping the clamps. These are the final fluoroscopic images of a stable construct.
Extra-articular fractures lend themselves to external fixation. At times, there may be a need to have a supplemental wire, as seen in this case. This is a multi-fragmentary impaction fracture, which even with traction could not be reduced. The major fragments were joysticked into place and the frame was erected. The carpal height index was restored. The eventual result in a 60-year-old woman was excellent painless function. This predominantly dorsally comminuted fracture extended into the diaphysis of the distal radius. The dorsal fragment could not be reduced and had to be joysticked back into place and secured there with supplemental wires. The fractures healed with good alignment and the patient had an excellent outcome. External fixation for distal radius fractures continues to be a viable method to treat even complex fractures. Most recent studies are prospective randomized studies, and these studies show excellent outcomes equivalent to internal fixations. When carefully selected and well executed, Mckee is an excellent external fixation device for management of distal radius fractures.
Thank you, Sudhir. That was
Thanks.
very neat, very neat. Okay, let's move on to the last talk by Jesse. Jesse, you want me to share the slides again?
Yes, you better share it.
Sure, not a problem at all. So this is on scaphoid non-union.
Yes.
Let me quickly share this. Are we okay?
Yep.
All right, all yours.
So we'll look at non-union of the scaphoid. And again, my disclosures. Scaphoid, for a little bone that's often injured in younger people, can have a number of complications.
Recently, the radiographs demonstrate a well-aligned.
So we're going to look at this non-union that's at least 6 to 8 months in duration. The incision has to be extensile enough that if you want to take distal radius bone graft and proximally to cover over the radial volar capsular ligaments, per se. We want to get down to the flexor carpi radialis and free up the sheath and retract the flexor carpi radialis ulnarward. And we're now approaching the volar capsule, and one can see a little bit of synovitis pouching out through this. The trick is to try to preserve as much of the radiocarpal ligaments as possible, either doing a Z cutting of them or just cutting the distal half of them, because we'd like to not induce an instability pattern. So we're approaching now getting rid of the synovitis around the non-union site. We're on the area of the proximal pole of the scaphoid. And looking down, as we'll free this up, we'll be able to appreciate the non-union. And this is a long-standing non-union, sufficiently so to have some synovitis in present. By spreading open the non-union, we can start to do a better debridement. The secret of all of these is getting rid of the chondral surfaces that are avascular, debriding them, drilling them until you induce some vascularity. Some people don't like to use a burr for fear that it's burning bone, so one has to be thorough and irrigating when you're doing this. But you've got to get through that sclerotic margins to get to bleeding surfaces. So what you're looking at, where the just proximal to this, that's the residual radiocarpal ligaments that we've kept in place. Freeing this up and debriding further till we have bleeding surfaces is probably the most important aspect of this treatment. And then we're spreading this apart and making sure that we can see both proximally and distally. The access to the distal radius is well recognized, and it's right there. I think there's a lot written and talked about by vascularized bone graft, but I think more than 90% of scaphoid non-unions can be treated with autogenous graft. And even if we're dealing with a humpback deformity, we found that you can realign them, and with stable screw fixation, use compact cancellous bone and avoid even have to put in a corticocancellous graft. So generally, especially in younger people, we can get a sufficient amount of autogenous cancellous bone from the end of the radius to fulfill the needs of this defect here. And by packing this in, this will fill up the three-dimensional defect very well. Here we've reduced the non-union and filled it with graft. Since this is a waist non-union, you could go either from anterior to posterior or posterior to anterior. But the secret, if you're going posterior to anterior, is to make sure you're in line with as close to the central axis as possible. It might be helpful to elevate a little bit of the trapezial footprint, because that will prevent you from forcing the K-wire to go in a more dorsal direction. And depending upon what device you use, variable. But again, probably a 40-degree pronated forearm view in the OR can give you about the best sense of accuracy of where that wire is. And once that's in, and especially in a young, hard bone, it's good to keep a wire in and then put a second wire to prevent, when you're doing this drilling, that you derotate the bone at the non-union site. So careful radiographic control, and now we're putting in a headless device and getting a good compression, per se. Now, repairing this volar capsular and ligament repair is facilitated because we've left half of it intact. And so we can get a very good repair of this capsule. And then skin closure, and that's really the end of the procedure. How you treat these post-op, especially in younger patients, I think they should be protected for at least 4 to 6 weeks, even with good stable fixation. Oh, thank you very much.
All right, good, great, thank you. Let's move on to some questions. There are some questions that I see. So the first question to Sudhir Warrior. Sudhir, how long you keep this X-Fix on, and when do you think this ligamentotaxis effect goes away, especially in comminuted fragments, to allow them to settle down and lead to early collapse?
Two parts to the question. When do I remove the frame? When the fracture tenderness is absent. So radiologically, it's very difficult to sometimes assess and say whether the fracture is stable enough, but fracture tenderness will always tell you that the fracture has healed. So if there's no fracture tenderness, that's the time to remove the frame, unless, of course, you have problems with some wires. And the second part of the question was?
When do you take care of those comminuted fragments? So
Yeah,
that
the question of ligamentotaxis.
Yeah.
Well, if there are impacted fragments, see, not all parts of the distal radius are connected to ligaments. Not all parts of them are connected to longitudinal ligaments. Some of them are oblique, some of them are strong, some of them are weak. So ligamentotaxis can work in extra-articular fractures, but in impacted fractures and intra-articular fractures, seldom do they give you the result that you desire. You therefore need to, at times, use joysticking to try and get the fragments in. And if you fail to do that, then you obviously need to open. So ligamentotaxis is something that came in with Schwin's idea of all the fragments falling into place, but I don't think it works very efficiently in intra-articular or impacted fractures. So you need to give up on that title of ligamentotaxis and use it only where it's applicable.
Okay.
Jesse, your views on this?
Yeah, I completely agree. The idea that traction will bring back those fragments, especially if they don't have soft tissue attachment, is not really applicable.
So let me take this further, Jesse. How often do you use X-Fix today for comminuted distal radius fractures?
Very rarely, actually. With a better understanding of fracture patterns and the use of CT scan, I think internal fixation is more predictable and certainly easier post-operatively. Let me say this, though, that for a number of years, this was the external fixation and pinning of the fragments was the standard treatment, and the results I had were very good, extremely good. So it's because we understood the fracture patterns. So I don't think that necessarily one is better than the other. It's a little bit more convenient for patients not to have the external fixation.
Sushrut, if I may, and I think it's important that I say something about this because I presented external fixations.
Absolutely.
I use external fixations very sparingly these days. And I use it on fractures where patients cannot afford an internal fixation. It's very cheap, Jesse and Mckee, that to have, it's much cheaper to put an external fixator on than to have a plate. A plate is very expensive. So given that, I use that in patients who cannot afford it. And I have, through this video, shown that the results are not any inferior, as have also been proven by those papers that I quoted. So I think external fixators is there. It's good. It's difficult. It's not the best thing to do, but it is a viable alternative.
Yep.
In a real distal fracture, where you know that the hold of the plate is not going to be very good, in such fractures, this external fixation is quite useful, I feel. And in order to see that comminuted piece which is there, you can put in a simultaneous bone substitute in order to give that healing process much more earlier, so that you don't need the external fixation for a longer time. And such real distal fracture without those really the spatial plates which can handle it now today, still I feel it is a much better option.
Prakash sir, you wanted to say something?
I have a question to Sudhir. There are many reports in the literature which say that if the external fixator or immobilization is kept for more than 6 weeks, then it increases the chances of CRPS. So I would like to ask you, you did not specify the time frame for which you will keep the fixator on. That's number one. And number two, did you also encounter the problem of CRPS in some of your cases?
Thanks, Professor Kotwal. That's a brilliant question. Brings out things that I couldn't put out in the video. Number one is the fact that when I use an external fixator like the one that we showed in the video, I always give a plaster slab for the first 6 to 7 days with the hand in the safe position. If you do that, and if the patient has got good movements within that plaster slab, the chances of CRPS are exactly equal or lesser than when you're doing a plating. If you do not do that, if your carpal height index, which was mentioned in the video, is not maintained, you're asking for trouble. So the moment you see swelling, the moment you see a reluctance to flex completely, you know this is the beginning and you need to attack it early. And quite oddly enough, the first few days, if they are able to move so well, they never become stiff if you maintain it for a long time. We've had patients on the fixator for non-unions and for other reasons for almost 3 months with no stiffness at all. So time and stiffness, I don't think have any relationship. I think it's how the initial first few days after the fixator go that matters when you're looking at CRPS. Have I had CRPS? Of course. When we started, we had a whole bunch of CRPS because we had stretched them out using distractors, which was a big mistake. There is no role for a distractor in an acute fracture. And that's a statement that I would like to keep on reiterating, that there is just no role for a distractor in an acute fracture. Whatever traction you give in your OT for an open reduction or a closed reduction, that's all you need. And that can be maintained easily by a fixator. A distractor puts pressure beyond that. When you're doing a malunion, when you're doing a lengthening, etc., or you're overcoming soft tissue stiffness. So we saw a lot of that because we were using distractors in the beginning in the 1980s.
Sudhir, I must tell you this today. Last during my master's MS, almost forced on me this thesis topic of ligamentaxis. So that was my thesis during MS Orthopaedics. Then I went to Liverpool, where I did the same topic, but it was modified ligamentaxis this time, because I had learned wrist arthroscopy and TFCC repair and radiocarpal ligament repairs done arthroscopically. Both got published in British GBJS. And I still use it for those 10-15% of the cases, irrespective of financial stature. But the patients in whom I think the swelling doesn't go down, you wait for 5-6 days, but the swelling is just not going down because of that particular person's physiological response to swelling. So I use external fixator for those patients. But I agree with you, ligamentaxis word needs to go out. It's just external fixation supplemented with KOS.
Yeah, sorry, it's a good idea. Yes, Jesse.
Oh, a few points. When we treated patients with fixator a lot, if you realize that patients tend to hold their forearm in pronation, they're somewhat reluctant to supinate. It's a little bit uncomfortable, and it just the thought of it, they're looking at it. As a result, two things were noticed. One was it was a little harder or slower to regain forearm rotation because they sat in pronation so much, the joint wasn't always perfectly aligned. And secondly, when reducing these, it was not always predictable that we reduce the rotation of the radius very perfectly. The advantage of the plate on the volar side is that that's the one thing it does correct. It corrects rotation. forearm rotation. By correcting forearm rotation, then your sigmoid notch and your ulnar head are in line. And the contact pressure in moving keeps it stable. So there was one advantage of the volar plate that wasn't initially appreciated, but we learned over hundreds and hundreds of patients that the regaining forearm rotation was more predictable. The second thing is, a lot is talked about a CRPS, but for the most part, in distal radius fractures, CRPS is a result of a median nerve problem. Or if you're using a fixator, it could be an injury to a radial sensory nerve. But if you see a patient that is, as you described, progressing in the wrong way, it's the median nerve. And if you release the median nerve, you frequently can abort the process to CRPS. So CRPS type 2 is what we tended really to see in many of these cases that were with distal radius fractures.
I'd just like to add, Dr. Tanna, we also use a bridging plate now for those kind of fractures that you were describing. And they seem to be doing very well. Leave the plate in for about 3 months and then pull the plate out and get them moving, and they move fairly well. Dr. Jupiter, because you mentioned about the supination, in the video it was pretty clear that we put the fixator on in supination, the plaster slab goes on in supination, and when you have an ulnar frame, it's made in supination. It's a coplanar frame in the transverse plane. And as you mentioned very rightly, that if they hold it in pronation, getting back supination is extremely difficult. Not only that, if a patient has full pronation and little or no supination or half supination, he's an unhappy patient. If he has full supination and no pronation, it doesn't matter. He's a very happy patient because the shoulder compensates by lifting up a little. And in supination, if he needs to compensate that, the shoulder needs to move across the trunk, and that's not comfortable at all and not functional at all.
Okay. Question to
Dr. Babhulkar, if I just say, I've got another meeting to go to, so I have to go. I apologize for that.
All right, no problem. Mike. Thank you. Thank you.
You're better dressed to the other meeting, I must say.
Mike,
Yes, Mike. You're saying something, Mike?
Great meeting. Great meeting. Thanks so much for the invitation. I learned a lot today, and thank you so much. Great to see everybody.
OTA this time, I don't think we'll be able to participate because huge Indian numbers are huge. So we'll miss you. And
we're so sorry to hear about the news in India. We'll miss you. We'll miss you in OTA. So the year after, we'll all be there. Okay.
Absolutely. Absolutely. Mike.
Best of luck, everybody. Thank you.
Thank you. Take care.
Bye-bye.
Take care. Okay. Question to you, Dr. Kotwal, is so is the Dirax completely out when you do mal-united distal radius surgery?
Well, it has its place, but as I said, in an elderly person, maybe with rheumatoid arthritis and not in an active person, and it is better rather than doing the Dirax, it is better to do a cuff resection or shortening of the ulna proximal to the head of the ulna. That way it is better because you are preserving the ligaments and you are preserving, you are not causing instability of the proximal ulnar segment.
Okay, so Tanna sir, unmute kara. Unmute sir, unmute
yourself, sir. Your headphones are missing, sir.
Huh?
Your head. Now you're okay. You're audible now, sir.
When you're doing the Suakapadanchi, the whole ulna is intact. So when you excise the ulna, the one which you showed, I thought it was a little too much of an ulna which you excised. But you can do the subperiosteal excision of the ulna so that the whole periosteal tube is intact. And then it will not be unstable at all. Particularly in Suakapadanchi, I think it is much easier to do it and you may not have to do any other reconstructing, because once the periosteum intact, all the muscles which are attached to it, and all of them are intact there.
Okay.
Any more remarks, JC, Vidisha?
I have for warriors regarding the use of bilateral frame. What is your indication of using ulnar frame in absence of ulnar fracture?
Bipolar.
That's a brilliant question. In the absence of an ulnar fracture, if the ulnar styloid remains displaced, what happens is because the patient is holding his forearm in this position, there's always a sag on the ulnar side. I don't want any pressure on the ulnar side. I want to relieve the pressure from the ulnar side, so I use an ulnar frame in such fractures. But if it's unstable, after I do the radius fixation, just as we would do and check in radius plating, if the DRUJ is very unstable, I would add an ulnar frame in supination and not go above the elbow.
Okay, thank you. If I can ask you, JC, when you're trying to do the release of the median nerve for a stiffness or do you do the EMG proof? Unless and until the EMG is involved, you will not do it?
No, what I'm describing is a patient with a rather acute presentation with pain out of proportion to the problem, with signs of hypersensitivity. And there's a study which describes the different parameters of CRPS called the Budapest criteria. And we have all seen these patients, and they're just not doing well. And frankly, in that group of patients, they can't tolerate an EMG. It's too painful. And then there's a second group that patients who have had fractures, they've had pain all along, but not the hypersensitivity, but they continue to be stiff and really not gaining sufficient functional mobility. And those patients at 2-3 months, you might be able to obtain an EMG, which may show a median nerve problem. And yet there's a third group of patients who may not even have a positive EMG, but the median nerve is a source of dysfunction. So in fact, we've come to go 180 degrees. I first realized it many years ago, that look for a nerve focus when you're dealing with CRPS. And if you can define it, you can treat effectively without adjuvant medication, without sympathetic blocks and whatever.
If I may add to that, borrowing from Martin Boye and Gelberman's paper about pre-existing symptoms of carpal tunnel. We never bother to ask a fracture patient whether he had any pre-existing symptoms that could be indicative of carpal tunnel. And if there is, or if there was such symptoms, then those are the patients that are likely to head towards CRPS, and those are the ones that will do extremely well with a release.
Yeah. And the personality of the patients, you can tell that this particular patient, based on the personality, he is going to land up with more trouble than usual.
I can never tell. And I think it's difficult. I don't know. Maybe I'm just a little slow there.
All right. So let's wrap up. Thank you very much. It was a great learning. Thank you, JC Jupiter.
Thank you.
Thanks for educating us. And the Indian team comprising of DD Tanna sir, Prakash Kotwa, Sudhir Warrior, my great friend, and Vidisha, of course. We are missing out on Ashish Babhulkar. I must also thank Anil Fernandez and Dr. Shobit Seth, and of course Shekhar Gitye and the team of Integrace to pull this together so nicely. And to keep this in the frame, Vaibhav Srivastav and Dr. Tarun Jain and Neha, of course, for giving a terrific backup. So thank you very much, everyone. We all had a great time. JC, see you soon.
Thank you.
And you take care.
And we wish your country the best in getting over this.
It's absolutely
Plague.
needed. Thank you.
Yeah.
Thank you.
Thank you.
Take care, all of you.